Bethell Joint Committee on Home and Community-Based Services and KanCare Oversight Committee to order. First up, we are going to have presentations on KanCare from individuals, providers, and organizations. And our first conferee will be Linda Mowbray, President and Chief Executive Officer of the Kansas Healthcare Association and Kansas Center for Assisted Living. Just a reminder to our conferees this morning, we are limiting to 3 minutes. So we will have Marisa will have a time on her on her phone, and she will hold that up when 3 minutes is up. So please be respectful of conferees behind you, that we are limited in time. So if you go over your 3 minutes, you're eating into their time as well. So we appreciate that. And first up, Linda, welcome to the committee.
Thank you. I am Linda Mowbray, President and CEO of Kansas Healthcare Association, Kansas Center for Assisted Living. And Mr. Chairman, I appreciate the opportunity to be here with you today and to provide testimony for this committee. Kansas Healthcare Association and Kansas Center for Assisted Living, we are a trade association that represents nursing homes, assisted living, home plus, many different adult care services across the state. And we've been around since 1951. First thing I'd like to do is to publicly say that our hearts and our prayers continue to go out to our residents, their family members, staff, those that have been affected by COVID-19. It's been a very difficult time for our homes, as I'm sure you're all aware, and we just can't say enough about how much support they need, and we appreciate anything that you're able to do for them. I want to start out by saying that KDH&E has been a great partner with the Medicaid application process since they have taken it back in-house. Chris Schwartz, LaTanya, Tanya, they have just been wonderful partners. The application process for nursing homes is going very well, timely, and they're able to communicate with us quite readily if they have issues and are needing to get in touch with a facility. There is an issue still with the HCBS applications, and that's not so much from a standpoint of getting them completed or done, but there is a gap between the time that a person applies for HCBS services and when the provider can get paid for those services. So if you're in an assisted living and you start running low on funds, the application process starts, and it is sometimes 45 days, 90 days before that application's done. The care manager is put into place, the plan of care is put into place, and during that time, there is no payer source. The facility is not getting paid for those services. So that is something that I realize that there is a senior task force hopefully being created soon. And I think that's an issue that would be very good for that. There's also a Senate bill, I believe it's 237, and it will look at those uncompensated funds. And I think that committee is something that we'd like to be a part of. I would say that, again, this COVID struggle has been very difficult for us, and our homes are doing a yeoman's job to keep the doors open. Census is down over 13% across the state, and we just really appreciate the continued compassionate outlook that you all have had as we try through these difficult times. With that, I will stand for questions at the appropriate time. There's other information in my testimony as you have an opportunity to read through it. Thank you so much.
Linda, thank you very much for your testimony, and conferees and committee members. We will hold for questions for conferees until after everyone has had an opportunity to present. Next up, we have Rachel Monger, Vice President of Government Affairs for Leading Age Kansas. Rachel, welcome to the committee.
Thank you so much, Mr. Chair. You can hear me okay?
Yes, we sure can.
Okay, great. It's nice that I can go back to back with Linda so we can try and cover as many topics as possible. And I gave you some very long written testimony that goes over a lot of the issues and gives you updates on our fight against COVID and long-term care. I just wanted to spend our couple minutes here today to talk about vaccine distribution and specifically what happens when our federal pharmacy partnership with Walgreens and CVS ends, which is relatively soon. And just as a reminder, the Trump administration set up a vaccine program to have CVS and Walgreens give 3 free COVID vaccine clinics at every nursing home, assisted living, and low-income senior housing site in the state. The program isn't perfect, but it has worked very well. And the only senior care or senior living sites that have had problems with vaccines are the ones who have had to rely on the state distribution because they didn't fall under this federal program. And as I said, this program is coming to a close. Um, the problem is that adult care homes still need vaccines for new staff and new residents, or current staff and current residents who change their mind about refusing the vaccine. And we hope that will be more and more people as time goes on and people become more comfortable with the idea of the COVID-19 vaccine. And so that's where a lot of our serious concern and anxiety lies, because we're not sure really what the state's plan is. Right now, we're told that homes must contact their local health department. And also, if they hear about a local pharmacy getting some extra federal vaccine shipments, we should try and hit them up as well. And that's pretty much it. And I think for obvious reasons, that hasn't really been good enough for our members, and it's caused a lot of anxiety and concern. Adult care homes, of course, are still the ones most at risk and still the ones that need a quick and steady supply of vaccines. It's also the fact that our residents can't just go line up somewhere and get a vaccine. It has to come to us. So I know that's an extra operational requirement as well. And so in this thing about calling your local health department, it seems like we aren't being prioritized even within the high priority groups, and no indication about any special distribution plan. So the ending of that temporary federal program isn't surprising. It was always temporary. And we're just not sure why the state's plan hasn't evolved beyond calling our local health department. You know, we know where the greatest incidence of severe illness and death occurs. So why does the state seem so unconcerned at this point about ensuring a dedicated supply of vaccines to adult care homes going forward? Because we know this pandemic is certainly not over. So thank you very much, Mr. Chair.
Rachel. Next up is Matt Fletcher. He's the Executive Director for InterHab. Nick, welcome to the committee. Or Matt, I apologize.
Sir, can you hear me? Can you hear my audio?
Yes, we can now.
Okay, wonderful. Chairman Hildebrand and members of the committee, thank you for the opportunity to address you today. On behalf of our member organizations that provide services to Kansans with intellectual and developmental disabilities across the state of Kansas, I'd like to begin my comments today by saying thank you to the members of this committee for your support of the IDD system in Kansas. And I think it's wonderful that House Bill 2046, a bill that seeks to continue to make progress on the chronic issues that plague the IDD system, was introduced this session on behalf of the Bob Bethell Oversight Committee. So thank you for your work. We do appreciate your leadership in continuing to examine and address the issues that impact Kansans with intellectual and developmental disabilities. We'd also like to thank you for support last session of the 5% provider rate increase that was included in the budget bill that was passed by the legislature in March of 2020. Unfortunately, that rate increase was swept as a part of mid-year allotments. We certainly understand the dire situation that the state found itself in mid-year last year, but we would ask that the legislature restore those funds now that we are starting to come out of the woods a bit on COVID-19. We'd like to also ask that you continue to consider the development of an interim committee process to examine the state's waiting list for persons with IDD. It's never been strategically examined to date, and we believe that a legislative committee process to examine and create recommendations is sorely needed to begin the process of elimination of the list. I'd like to conclude my comments this morning by asking for your help on an issue that continues to vex the community provider system, and that is vaccinations for Kansans with intellectual and developmental disabilities. There continues to be a great deal of confusion surrounding the IDD community as to exactly where they fall into the state's phased vaccination plan. Some of our members report that they have been able to successfully have Kansans with IDD that they provide supports to vaccinated. Other providers in other parts of the state have indicated that their local health department or pharmacy has turned them away when they've tried to have Kansans with IDD vaccinated because they point back to the state's phased vaccination plan, and this population is not clearly pointed out as prioritized under phase 2. Other states have prioritized the IDD population. We believe that is the smart thing to do, as research shows that this population is between 2 and 10 times more likely to die from serious complications due to COVID-19. So they are a vulnerable population to COVID-19 and deserve to be prioritized. With that, I'll stop, and I'd be happy to answer any questions on part of the committee.
Thank you for your testimony, and we're holding questions until the end of all the conferees. Next up, committee, we have Nick Wood. He is the Associate Director for InterHab. Nick, welcome to the committee.
Thank you, Chairman. Members of the committee, thanks for having me. Can you hear me okay?
Yes.
So I'll try to be brief. Matt talked with you about the waiting list and a number of other issues that we're working on with regard to long-term supports and services. I also, in my role at InterHab, work with an internal task force looking at the complex care needs of people with intellectual and developmental disabilities in Kansas. I always like to update this committee on our activities, but just want to give you a quick rundown. Please just let me know if you have any questions, or we can come to you for follow-up. But essentially, the complex care needs involve all of those things that affect all of our lives: behavioral health, medical health, and also age-related conditions. They're sort of apart from or a part of their long-term supports and services needs. So at InterHab, we've been working on developing models around community-based care management. This is to try to improve our systemic practices around how we get medical health care needs met for people with IDD. How do you find an accessible doctor's office? How do you coordinate healthcare, nursing services, and that sort of thing for people who have complex care needs? A lot of those needs are met by direct support professionals who don't necessarily have that kind of training. So there's a lot that goes into training folks and helping them be confident to be able to handle those needs. Our next initiative is something there's a bill that is being reworked, or amended really from last year, that would address the needs of people with IDD who get involved with the criminal justice system. And so there's been an effort for a long time to sort of identify some issues in our civil commitment statutes, but also just questions about what are the appropriate types of services that a person who is accused of a crime but is not able to stand trial for a crime because they're not competent. What kind of community-based needs do they have? It's been a long conversation, at least like 20 years old. And the Judicial Council, about a year and a half ago, formed a committee. They wrote language that would amend our statutes to kind of bring them up to where we should be and prevent people from just going to Larned for competency restoration, but provide an alternative. So that's what we're working on. There is a bill that doesn't have a bill number yet, but it was Senate Bill 333 from last year. We've talked to this committee about that before. We're going to continue to work on it. We'll just continue to update the committee. Our last initiative is around statewide mobile crisis support program. And if we look at my testimony, you can see a description of what that would look like. We actually have a bill. We had an informational hearing last year, and we were able to provide a lot of
Nick,
testimony.
I apologize, but we are out of the time on that. So
Okay.
I appreciate your testimony. And committee, next up for conferee is Matt Johnson. He is Director of Business Operations for Maxim Healthcare Services. Matt, welcome to the committee.
Chairman, can you hear me and see me?
We can hear you. Now we can see you.
All right, great. Well, Chairman, committee members, thank you very much for allowing me to speak today. My name is Matt Johnston, and I work for Maxim Healthcare Services. We are a provider of specialized medical care through the TA waiver and the IDD waiver. Specialized medical care refers to nursing services that are provided in the home to severely injured pediatric and adult patients. I'm here to ask the committee to increase the reimbursement rate from $31.56 to $47 per hour. The current rate is one of the lowest in the country and hinders us from being able to recruit, train, and retain nurses who will provide these vital services in our communities. Currently, around 65% of the authorized services are being provided. That's the equivalent of a doctor saying that you can only have 65% of the medication that you need to get better. These are necessary services that patients need to survive and thrive within the community. With the current reimbursement rate, nurses are having to take 60 to 70% of the pay that they'd receive in any other healthcare setting. Nurses want to work with these patients in the home, but cannot because of the financial hit that they would have to take. Over the years, Maxim and other specialized medical care providers in the state have advocated for a rate increase, worked collaboratively with the legislator, KDADS, KDHE, and have identified multiple different avenues to fund this increase. The first one is legislator could request for a caseload transfer from KDHE Medicaid budget to KDAD's budget. This could make the cost of the increase almost revenue neutral based on the research that we've done. The second option would be the legislator could allocate new state general funds to the appropriate waivers. The estimated cost of the new state general funds would be around $9 million. The legislator could also do a combination of both of those two things. Our research has concluded that it would take 1.02% reduction in hospitalization days from just the specialized medical care patient population to cover the cost of the increase. Think about one of the patients that Maxim takes care of who spent their first 637 days of their life in the hospital. Then knowing that that patient could have been home for over 200 of those days, but had to remain in the hospital because there was no support for them in the home. There are over 600 Kansans that receive this service. Imagine the cost savings the state could recognize if specialized medical care was provided at the level that it's supposed to be. I've worked for Maxim for 14 years and been honored to meet some of the strongest patients and families in our communities who require this service. As a parent, I know the excitement you experience when the day your child is born. Many of these families had the same feelings until their life was changed when a doctor told them something went wrong. Many of us worry about our kids being safe at school, safe with babysitters, safe with family members. These families have to worry about their kids staying alive when they leave the home. Please increase the specialized medical care rate to $47 per hour for fiscal year 2022 and moving forward using any funding mechanism necessary. One final note, there is written testimony from Addie Begley, who's a neonatal intensive care nurse practitioner at Children's Mercy, that also talks on this topic. I just wanted to bring the committee's attention that testimony also addresses this topic. I will be here for any questions that you might have, and thank you very much.
Thank you very much for your testimony. Committee, next up, we have Dr. Janet Williams, President of Minds Matter, LLC. Dr. Williams, welcome to the committee.
Thank you so much. It's good to be here today. I'm a frequent person who testifies to this committee, and I really appreciate your time. The brain injury waiver in Kansas is 30 years old this year. That's 30 years of assisting people to leave hospitals, rehab centers, nursing homes, homeless shelters, state hospitals, jails, and substance abuse treatment. In total, more than 70 referral sources. Last year alone, we had 118 referrals from hospitals, including the University of Kansas, Stormont Vail, and Via Christi. What I'm here to talk to you about today is some great things that the legislature has done. 2 years ago, the definition was changed from someone with a traumatic brain injury, which means externally caused car wreck, motorcycle, gunshot, falls, to people with acquired brain injuries, which means someone with a stroke or internally caused. For 28 years, we let everybody know that they needed the same services to live at home, and that change was made. Also included were children. And so now people from birth to 65 are eligible for this program. In addition to that, the state of Kansas recognized that there were no services in Wichita and in the rest of the state. Northeast Kansas, where we're located, was not fully served, but served quite well. And so services have also expanded to Wichita and across the state. The challenge we have today is all of those great policy changes have led to the fact that no money has ever been added to the waiver for those changes. And KDADS has been testifying this year that they face an imminent waiting list, which they anticipate would be as soon as May 1st. And I am writing to you today and speaking to you today to urge that there not be a waiting list. The beauty of this waiver is it's time limited based on progress. The average amount of time someone is on this waiver is 2 to 4 years. COVID has certainly impacted that, and fewer people have gone off. KDADS has brought together a great stakeholder group that's going to look at some of those policies to help people transition off faster, but that does not solve our immediate crisis. And that crisis means that if there's a waiting list, everybody waits. The 26-year-old in a nursing home in Manhattan who had a stroke, when her name comes to the top of the housing list, she waits. The 14-year-old with a single mother in Wichita who's currently in outpatient rehab that's about to end, he waits. His mother will have to stay home to care for him, lose her job, and they might become homeless. I've spoken to this family 3 times, and every conversation is very tearful and emotional because she's very scared. Thankfully, we hope he can get on the waiver before a waiting list were to happen, or maybe we can prevent one altogether. The 30-year-old who's been at the University of Kansas hospital for 119 days because they can't find a nursing home for him, he waits. Even though his mother has finally found a 1-level house she can take him home to, waiting does not save money. Waiting really does cost lives, and we know that. We know that people should not be going to congregate settings right now during COVID, and a lot of the people we work with have trachs, feeding tubes, and require lots and lots of care. This program provides far more than a nursing home. A person receives physical therapy, occupational therapy, speech therapy, cognitive therapy, behavioral therapy, attendant care, transitional living skills, home modifications, equipment, and care coordination, all things at a far less cost than the hospital and to a far greater benefit to any facility. If people are forced to wait in a nursing home, they'll regress, and the future therapy will take longer and cost more. So today,
Dr.
we're
Williams.
asking that the funding to the brain injury waiver be added to caseloads to avoid a waiting list. So thank you very much for your time.
Thank you, Dr. Williams. Next up, we have Haley Ordone, Chairwoman for the Kansas Adult Care Executives. And committee members, would you check your laptops and make sure your volume is muted, please? And Haley, welcome to the committee.
Yes. Good morning. Thank you for having me. Always appreciate the opportunity to testify in front of this committee on behalf of Kansas Adult Care Executives. We represent the professional that is the administrators, the operators of long-term care, skilled, assisted living, independent living. Rachel had already touched on the vaccine distribution and the needs there, so I appreciate that, and I will save that from my testimony. Just know we agree with the importance of that. I'd really like to take your attention to the majority of my testimony regarding fiscal and budgeting. And to reference page 2 of my written testimony where there is a chart so that you can understand the picture I'm trying to paint to help you understand what we're facing right now. Of course, you know, we always advocate that the Medicaid reimbursement rate does not even begin to fully touch the needs of what our services we must provide are. This last year, we were set to have a 1% increase. Of course, that got cut with the expenses and the pandemic. But we would ask that the money that was allocated for that funding, that it stay there. We are very fearful that perhaps the money that is supposed to be allotted for paying for room and board for our long-term care and assisted living settings could possibly be taken out and seen as a extra amount that's there that could go towards other services or, excuse me, other Medicaid expansion areas. So we ask that we keep those funds there for the nursing home reimbursement and or additionally possibly utilize that to go back towards some of the nursing homes that have really had that have suffered so much from low census. Of course, we would obviously assume that we would have to demonstrate a financial shortfall, almost like the federal PPP program. But if you look just at two buildings, two of our members, the bottom one actually happens to be my facility. You can see in there what our prior census was, current census. That daily rate is the Medicaid daily reimbursement rate set. That's individualized per facility. That's how much money on the daily loss that we're losing monthly, annual. And then on top of that, we contribute towards the bed tax. We pay in a set amount of $818 per bed that we then turn around and match funds on a federal level to pull it back into our reimbursement. That's extra money going out of our operations along with the shortfall that we have. Many of our members are fearful whether we will be able to survive the next 6 to 12 months in operations. And I don't think any of us want that picture. So I really want to stress the importance of our needs there. We would also ask too with this that there could possibly be a modification currently for the bed tax. For our licensing on the building, we can increase twice, but only decrease once. And that has to wait and not be done until the next fiscal year when that starts. So that is a real hindrance. We would like to see if maybe we could collaboratively work together on something there. Obviously, you can see in the testimony, we'd like to advocate for opposition to House Bill 2004 and support House Bill 2126. I would also hope that you would take record of the last page of my testimony for how we move forward. I think a lot of people are under the assumption that with vaccine distribution, we can reopen, and that's not the case. So I thank you for your time, and I'm happy to stand for questions at the appropriate time.
Haley, thank you for your testimony. Committee, next up we have Luann Kebby. She's Systems Advocacy Manager for Southeast Kansas Independent Living Resource Center, Incorporated. Luann, welcome to the committee.
Thank you. Express appreciation for KDAD's working with the Centers for Independent Living to get PPE to our customers and their workers, and then also getting tablets for us to provide for some of our customers. These things have really made a difference these last few months in people's lives. So I just wanted to recognize them for that. And then our ongoing concern that we've talked about for the last couple of years is the protected income level and client obligations that many of our individuals are required to pay. We appreciate the increase that was done in 2019 and 2020 that has helped individuals, especially this last year, I think, through the pandemic, as everyone's experienced financial problems. So, but some individuals whose client obligations that went away in 2019 are now experiencing a client obligation again because there was a cost of living allowance adjustment for January 2020 and January 2021. So as well as individuals whose client obligation may have been reduced because of the increase, the recent increase was not eliminated in 2019. Their client obligation has been going up these last because of these last two COLAs. So Skill is asking that this committee take the lead on increasing the protected income level to 300% of SSI, which is the maximum allowed by federal regulations. and also follows. The majority of the states are already doing the 300% of SSI. We do have customers that are still struggling to pay their client obligations. They're unfortunately having to choose to pay that over sometimes utilities and food. We have individuals who are concerned that if they can't pay it, that they'll have to go to a nursing facility, which is not what they want to do. I have attached some stories, letters from some of our customers, so that you can actually hear from them personally. And then I'll also be emailing some other, some more letters as our customers share their concerns with us. I'll email them to the committee. So increasing the protected income level would help individuals, especially a lot of these individuals are people who worked most of their lives and now are, you know, either in their late 50s on disability or on Social Security on the FE waiver even. And we would really like to see them be able to keep the money that they've earned to be able to try to live a little more comfortable in paying their bills and purchasing healthy foods and those things. So we would appreciate that. In addition, Skill also supports.
Luann, I apologize, but we're past our 3 minutes, so we're going to have to move on to the next conferee. Thank you for your testimony. Committee, next we have Leslie Anderson, Executive Director for the Kansas Association on Area Agencies on Aging and Disabilities. Leslie, welcome to the committee.
Thank you very much. Can you hear me?
Yes.
Thank you. I'm Leslie Anderson, Director of K4AD, and I want to thank you very much, Chairman Hildebrand and members of the committee for allowing me to come and talk to you today. I represent the network of the 11 area agencies on aging that have a statewide coverage. You have my written testimony in front of you, and I'm just going to touch on a few points that's contained in my testimony. There's a constant message resonating about the impact of COVID, and to give some perspective, in FY 2019, the AAAs completed 12,946 care assessments compared to 11,024 in FY 20. These mandatory assessments are needed for a person to stay in a nursing facility and for the facility to receive payment. The AAAs are also contractors for the Aging and Disability Resource Centers and the statewide call center, delivering objective, unbiased information to locate long-term care services and resources. In 2020, the ADRCs performed about 14,000 functional assessments for people to access the BI, FE, and PD waivers and the PACE program. In 2020, the call center reported a 25% increase in contacts if the trend continues for the remainder of the year. During the last 12 months, nursing facilities have been targets of devastating outbreaks, and potential KanCare customers who fear entering a nursing facility apply for a crisis exception, bypassing the PD waitlist. Since March, 393 applications were submitted, and currently there are 167 that are being processed. The administrative case management is a service exclusively for individuals who are functionally eligible by FEPD waivers and PACE program, but need assistance navigating the complicated financial eligibility process. Since May, the ACM reported an average of 404 individuals receiving assistance per month, and right now that average is about 500 individuals per month, with a satisfaction rate of 95%. Considering the committee, is to monitor and study the implementation and operations of the long-term care system, I think it is appropriate to touch on the statutory Senior Care Act program. Available only to Kansans age 60 and over, the Senior Care Act is a cost-effective program delivering in-home services, case management, personal emergency response services, and/or respite care. This program diverts individuals from costlier care. When you look at the state share of 40% for Medicaid, senior care plan of care costs 80% less than a nursing facility and 53% of the FE waiver costs. The plan of care of a $280 monthly average means that each customer pays an average of $75.60 per month. There's about 400 or 4,000 customers on the program, and they remain on the program for about 30 months. So you can imagine the savings to the state. We ask for your support of this program. I've also included recommendations because this not only affects the aging, but also people with disabilities and caregivers that the AAA serve. We want you to study all the wait lists and appropriate adequate funding to meet the growing demand, and appoint members to the State Advisory Council on Aging and its subcommittees.
Leslie, I apologize, but we're past the time, so we'll have to move on to our next conferee.
Okay, well, thank you so much.
Thank you for your testimony. Committee, our next conferee is Margaret Farley, Executive Director for the Kansas Advocates for Better Care. Margaret, welcome to the committee.
Thank you, Chair. Thank you, Chair and members of the committee. I am appearing before you before this Oversight Committee for the first time, as I am replacing a person that you're very familiar with, Mitzi McFatridge, who resigned after 13 years of service to Kansas Advocates for Better Care. So I have really big shoes to fill. I just wanted to introduce myself briefly. I have been involved in nursing home reform issues since at least the early 80s. I was a board member way back in the 80s of what was then Kansans for Improvement in Nursing Homes. The name now, of course, is Kansas Advocates for Better Care. We have worked for the last 46 years to improve the quality of long-term care in the variety of forms it now takes. Our testimony today concerns the priority of restoring the strength and ability of the survey process. We are concerned that surveys are reduced in number. This, of course, occurred during the COVID emergency, and we are concerned that KDADs have sufficient money, that the survey process is strengthened in terms of the numbers of surveyors and the numbers of regular and complaint surveys that are done. Of course, I testified, so some of you have heard this in regard to the nursing home survey process. We want adequate money for that. But we are concerned, especially since the crisis of the COVID pandemic and how the surveys were limited. We are concerned because those surveys are attempting to take care of regulatory violations. We know what has happened in facilities. In many cases, the trauma had to have been unimaginable. It is important to get surveyors back into facilities. And the key issues that we are concerned about with regard to surveys are exactly what we're hearing here today in terms of vaccine issues. We understand that staff members are having some difficulty getting their numbers up in terms of vaccinations, as well as residents, and we're concerned about that. We're concerned about restoring visitation and staffing, which was a key problem, infection control, resident rights, and all of these things are of great concern. We note that the Senior Care Task Force has one of its topics to be surveys and fines, and we think that came from the industry. Of course, we support surveys, and we hope that process is improved over the next year. Thank you.
Thank you very much for your testimony. Committee, next up we have Mike Burgess, Director of Policy and Outreach.
Oh, howdy, Mr. Chair. Can you hear me okay?
Yes, welcome, Mike.
All right, well, thank you. So I think most of you know me and are familiar with our organization, so I'll jump right in the interest of time. As previous conferees have mentioned, I want to say ditto on funding some additional slots, or the need to fund some additional slots for the brain injury waiver. I think the agency, there are a few things that the agency has done. I recently participated in a stakeholder group that I'm assuming that the state will brief you on later, but talked about a few things that they can do to help kind of proactively manage the waiver list, to help, because the key with this being a rehabilitative waiver is to get some churn. You want people on the waiver, you want them to get services, and then ideally then they're able to transition off. And that has been a challenge, with COVID has created some additional challenges there. And I think the agency has some good ideas and received some good ideas from the stakeholder community to help address that partially. So while that will help, I do think there's need for some additional capacity there. I do want to share our support for that as well. I'm going to shift hats really quick, because at the last meeting I spoke on behalf of the Kansas DD Coalition. I just want to give you an update on some of the work that we've been doing as a coalition on studying the needs of individuals on the waiting list. And just kind of a quick refresher, that waiting list is up over 4,400, nearly 4,500 individuals. Often, people are on there at least 8 years and possibly even 9 years. Most of the folks who are entering services aren't doing so because their slot on the waiver came up. It's because they had a crisis. And obviously none of us are, like this situation. But the thing that we need is to know the needs. And obviously over 8 or 9 years, an individual's needs evolve dramatically. And so we think a good starting place would be to have that discussion, or do a study of the needs of the individuals on the waiting list. I'm happy to report we had a great meeting. So we've been talking about that as a coalition for several months, including at all of our meetings and including some additional meetings. We recently had a meeting with KDADS, and I'm hoping that they can brief you more on it later. Very positive discussions about some of the ways that you could accomplish this task. I think the big takeaway is that doing this study is very doable. It wouldn't have to be entirely complicated. I know the agency has a lot on their plate, but there's ways that they can do it that would have a minimal impact on the agency, bring in the right expertise, and help the agency as program administrators, help legislators as appropriators, and help providers be prepared to be able to provide services to individuals. We think that is very complementary to the interest in having either an interim committee or some sort of task force to study the waiting list, because they'll need data to talk about. So those two items are both positive. We want to support those and appreciate your support for them. The final item, a bonus item, is just also the support raising the protected income level. That's a big barrier, keeps people from entering nursing facilities. And obviously lots of good things to raising it, and want to encourage you to join the majority of states who've set it at 300%. So with that, Mr. Chair, I'd be happy to stand for questions at the appropriate time.
Mike, thank you for your testimony. Committee members, we are now going to hear from Craig Knutson, Policy Analyst for Kansas Council on Development Disabilities. Craig, welcome to the committee.
Thank you very much, Chairman Hildebrand and members of the committee. Can you hear me okay?
Yes.
Okay, thank you for the opportunity to speak to you today. The Kansas Council on Developmental Disabilities is made up of self-advocates, family members, state agencies, and our partners identified in the Federal Developmental Disabilities Act. Federal and state statute created the council to advise policymakers on issues that impact people with developmental disabilities and their families, as well as carry out activities that increase self-advocacy, systems change, and capacity building. Speaking of capacity building, today I'd like to talk to you about the waiting list for IDD waiver services in Kansas and what we know and what we don't know about it. Understanding who is on the waiting list in Kansas is crucial if we are to understand, anticipate, and plan for what type of supports and services people coming off the waiting list actually need, when they need them, and where they need those services. There are a lot of things about the waiting list that we currently do not know, but one thing that we do know is that the waiting list continues to grow and the wait for services is getting longer and longer. In 2012, 3,266 Kansans with IDD were on a waiting list for HCBS services. By January 10th, 2020, that number had swelled to 4,086 individuals, despite the state serving more people. The most recent data from January 19th, 2021 shows that there are currently 4,464 Kansans with IDD waiting for home and community-based services, and this represents a 9.25% increase in the size of the waiting list year over year. What makes this increase all the more alarming is what we don't know about the waiting list. The sad reality is that we, as a state, really don't know what the needs are of the people on the waiting list. And the truth of the matter is we've only identified a small fraction of Kansans who may be eligible for home and community-based services. As a solution to this problem, the Kansas Council on Developmental Disabilities joins with other conferees in recommending that the state of Kansas undertake a data-driven deep dive into understanding, number one, the makeup of the current IDD waiting list, two, what the needs are of the people currently on the waiting list, three, understand the characteristics of people who are entering services due to crisis exceptions, and finally, develop recommendations on how to anticipate future supports and service needs based upon those findings. It's time for us to reverse the trend of a perpetually growing waiting list in Kansas, and we can't reverse that trend, however, without understanding the underlying reasons why it is growing, who makes up the waiting list, and what services and supports these Kansans actually need. Thank you for your time and consideration, and I will be open for questions at the appropriate time.
Craig, thank you very much for your testimony. Committee, next up, we have Sean Gatewood, Co-Administrator for KanCare Advocates Network. Sean, welcome to the committee. Sean, are you available online?
Let's try that. Can you hear me now?
Yes, we can. Thank you, Sean.
Thank you, Mr. Chairman. Sorry about that. I thought I had myself unmuted. Thank you, members of the committee and Mr. Chairman, for allowing me to testify before you today. I'm going to keep it short and sweet, as most of my colleagues and members have covered most of what I had to say. We very much support studying and understanding the waiting list and preventing a new brain injury waiting list. I would just add that I think we also need to take a look at the PD waiting list in addition to the DD waiting list. It's not nearly as large, but just in general, eliminating the waiting list is something that we support. The protected income level, I think that the legislature was very wise to increase that amount a couple of years ago. And there's consideration now of putting that into statute. Having that be not a static number, but indexed to where we don't have to revisit would be a very big win. But I would echo my colleagues and say that I think that we should join many other states that have increased theirs to 300%. And just as a preventative measure, trying to keep people supported in the community as much as possible. We also I lost my train of thought. Yes, absolutely. But keeping that or increasing that to 300%, I think is a worthy cause, and I think it's also worthwhile to always note and remember that when we're talking about waivers, you are in fact waiving something. And in this case, you're waiving your right to institutional care. Again, keeping people in the least restrictive setting as possible, allowing them their freedom. It is a worthy goal that I think the protected income level, along with some of the other issues that we're facing, would help. So I will stand for questions at the appropriate time. Thank you very much.
Sean, thank you very much for your testimony. Committee, I would at this time, this is all the verbal testimony that we have. We do have some written testimony, and they are online from Addie Begley. She's a private citizen. Barb Helm, Executive Director for KanCare. Amy Heighton, Executive Director for the Topeka Independent Living Resource Center. And Christy Wells, Policy Director for Oral Health Kansas. Committee, at this time, we are going to open up for questions for the conferees. Do we have any questions for the conferees? Representative Carpenter.
Thank you, Mr. Chair. This question is for Janet Williams.
Yes.
Janet, how many folks are from out of state on this waiver?
Everybody is a Kansas resident, if they go on their private insurance, say to Madonna in Nebraska or another out-of-state facility, Craig in Denver, they may qualify for Medicaid while they're there with their Kansas residents and then come back home. Kansas Medicaid, to my knowledge, is not currently paying for anybody out of state. And if they are, it's very few, but that would be a question for KDADS. So they're all Kansas residents. If they go out of state, it's on their private insurance. Then their insurance runs out and they have to come home, or they're done with rehab out of state.
Okay, and then, so also, what would you say the average length of time on this brain injury, this waiver is?
Pre-KanCare, our agency was at 1.9 years. There is a policy that if you're on for 4 years, a review kicks in and you have to tell people how much longer you want to stay on the waiver. And not just tell, you have to prove. So say someone is, very close to completing a goal at 4 years, it could be extended for, say, 6 months to finish up that goal.
Okay, thank you.
You're welcome.
Committee, do we have any other questions? Representative Concanon.
Thank you, Mr. Chair. I think I'll address my question to Rachel Munger. Are you there, Rachel?
Yes, I am.
So I have received a couple of constituent kind of complaints about the visitation in the homes during COVID. And I mean, the number of those has dropped off significantly, but I was wondering if you could just real briefly tell us what the status is of, is it home by home or is there a state policy? So where are we at with COVID visitation in the facilities?
Mm-hmm. So mainly what is restricting visitation is federal guidance from CMS, and the degree to which you can open up to visitation is dependent upon many times the rate of infection in your community and county, as well as what's going on in your building. And our national association actually talked to CMS this last week, and they were very adamant that they were not changing their visitation guidance anytime soon for a variety of reasons. And so we are still stuck with that. Now, as rates especially start to come down, we're very hopeful in the next month as vaccines go through, then we should be able to open up more and more for visitation.
Great, that's what I needed to know. Thank you very much. Thank you, Mr. Chair.
Representative Ballard.
Thank you, Mr. Chairman. My question will be for Matt Fletcher.
Representative and Chair, Matt actually had to leave the committee meeting a little bit early.
All right.
I could try to answer your question.
Well, I think you will do just fine, Nick. He talked about our 5% provider rate increase, which we had approved last year, but didn't get the funding. Could you just really tell us again why that provider rate increase is so important?
Sure. As far as keeping up with the rate of the cost of services over the last 20 years, we're just very far behind. There's pretty large turnover rates all over the state. It's not just with InterHab members, but it's difficult to find staff who will be able to work with Kansans with IDD, especially considering their complex care needs. Things like the pandemic certainly have made it more difficult to hire and keep staff. Just being able to train staff while you're experiencing 50 to 70% turnover in a year is very expensive. So any increase in the rate, any increase to their wage helps reduce the turnover. It really helps our system exponentially. You heard testimony, I think in the budget committees this week about how one of our members was able to give kind of, appreciation pay, I think they called it, or hero pay, I've heard it called, to help retain staff during the pandemic. And there was a wonderful decrease in their turnover. So it just goes to show that adding a little bit to the rate and a little bit to their wages really helps the entire system. People get a lot better services.
Well, thank you very much for your response. I asked that question because we knew it was important last year. That's why we approved it for the funding. But since then, I'm sure many of us have received so many more letters or emails, I should say, from people, because with COVID, it has made it even more of a crisis for them in terms of working and availability, which we know that in this area, you normally have more women that are working pretty much in this area. And these women have had to stay home because of schooling and childcare not available and all of that. And I just wanted to put a little plug in for that because it has created a really hard hardship for women in this area as well.
That's right.
And just
That's right.
trying to find someone. We were having trouble before, but now it's even more of a crisis. So thank you very much.
Yes, ma'am.
Thank you, Mr. Chairman. I appreciate it.
Senator Gossage.
Thank you, Mr. Chair. My question is for Leslie Anderson. And it was mentioned, let me wait till she gets on.
I'm on. Can you hear me?
Yes, I can.
All right.
It was mentioned by a couple of the folks that have given us, or the conferees, about the waiting list. Can you address that as to how many people are on this waiting list for services?
So which waiting list are you referring to?
I know of one, and maybe you could enlighten me of others, but I know that there has been a waiting list of some 5,000 people waiting for services under Medicaid. And can you address other waiting for services?
Sure. So depending on the waiver, there's a wait list. The one that Janet was referring to has not started yet, but we do continue to do the assessments. So the IDD waiver is a lot more than the rest of them. I wish I could get into the system and actually look at a solid number for you. But I can talk about how, when you're talking about the wait list, how the ADRCs can respond to that, and that is with the crisis exception when a person meets all of that criteria. I believe, and somebody who probably has access to the system while I'm talking to you might want to come up with those specific numbers. Oh, so the PD wait list is around 2,100. And the what they do is when that number gets high enough and there's a release, then those offers are made. The DD wait list is about 4,500. There is not a wait list on the frail elderly.
That's the 4,500?
Yes.
Is the elderly?
No, there is no wait list on the frail elderly.
No wait list on the frail elderly. Thank you.
Senator Gossage, Secretary Howard is testifying later this afternoon. She might have better answers for you on your question.
Thank you very much, Mr. Chair, and thank you.
Thank you.
Not seeing any further questions from the committee, we will now turn our attention to the presentation by our KanCare Ombudsman, Carrie Bacon. Welcome to the committee.
Thank you very much, Chairman. Can you hear me?
Yes.
Okay. My name is Carrie Bacon. I'm the KanCare Ombudsman. I appreciate having time to share information about our office with you today. If you, one of the things I wanted to just mention at the beginning is that the report is long and it seems to grow, but the information that is in here is based on information that is required through the KanCare special terms and conditions that were put together in agreement with CMS. And so a lot of this is required information. And the other thing I guess I would like to help you remember is that even though these are numbers, they are representing people who contact us requesting help. And we take that very seriously. And sometimes it's easy to get lost in numbers, but to remember that these represent people and their lives and what they're trying to get, they're trying to accomplish through Medicaid in their health. First of all, what I'd like to do is let you know about our offices, our satellite offices. We're open in fourth quarter in Kansas City and in Wichita. We had 2 volunteers in each office that were able to come back in spite of COVID. We have COVID protocols in each of those offices to make sure that they are safe while they're there. Also, we hired a volunteer coordinator, went through the process in December. The volunteer coordinator started on January 25th. Her name is Josephine Alvey, and she is a new graduate of Wichita State University. She was a full-time volunteer, AmeriCorps Vista volunteer. I think you've heard me reference that program before. She worked for us for a year while she was going to school. She was doing school full-time and going to doing her AmeriCorps Vista program. And we are very excited to have her with us. She's very good with volunteers and understands our resources. Second, I wanted to just bring to your attention on our web pages that we have a landing page now on our web pages. Before, it usually just went to About Us, and I decided that we needed to maybe help people understand a little bit more about what we do when they got to our web pages. So that is a new thing that has happened. And third, we have a new brochure, and I would really like to direct you to page 23 in our report to take a look at it. The brochure that we had before was 4 pages. It was put together pretty soon after I became ombudsman because there were a lot of questions about what our office did and some of the programs that we had available. So that old brochure talked about our office. It talked about our liaison training program with community providers. It also shared about volunteer program that we do. And then the back page had some resources that were pretty basic that we thought people would want to have. Our new brochure is 1 page. The front is English and the back is Spanish. And it is very much directed just to the member to help them understand what we do and how we can help them. We made a lot of them, and we have already been sending out these brochures to community providers as opportunity arises to help them share this information. The last thing I wanted to bring to your attention, just kind of as the highlights, is that CMS likes to know what we have cooking, what's coming up in the future. And our office has been working for a year, almost 2 years, on putting together community resource pages for every county. I heard in one of the testimonies before that people are struggling with food, with paying utilities. A lot of times people don't know all of the resources available in their town or in their county. I have come across those people that say there's nothing here, and it's part of why we started this. When I did some research, I found 10, and she only knew about half of them. And so our goal is to try and help people that are on Medicaid or have a spend down, and so their resources are very limited on what they can spend their money on, to find some other resources within the community. So that will be coming out in first quarter. So that's what's on we have 2 interns from University of St. Mary's in Kansas City helping us with this project. We've had several over the time helping us with this. These two are going to help us finish it, and then we will get it on our website. I would like to just take a couple of minutes and have you look at the table of contents of our report, just to familiarize you with the information that we provide. We do a highlights or dashboard. Usually it's one page to tell people what's the new stuff that's going on in our office. Then I added about a year ago what our purpose is, so that someone who maybe is not as familiar with our office would get some information about what our purpose is and why we're placed with the state of Kansas. Then the next part is about accessibility, and it talks about our initial contacts and the accessibility to our office through our volunteer program. Then we also talk about our outreach. We outreach to members, community partners, providers, a lot of different groups, and we have some data just showing the numbers, and then the actual list of the outreach that we've done is in Appendix A. And then comes the data, and all of this is kind of data, but the other data that is specifically requested by region, by office location, by contact method, caller types, and especially the issues category. It's why are people calling? It has gotten so big that we have divided that into 3 parts. What are the Medicaid issues? What are the long-term supports and services issues? And then what are some of the other issues that may be related to Medicaid, but not exactly Medicaid? So foster care, Medicare, Social Security, those things are kind of, they're related to what we do, but they're not exactly KanCare. And then action taken shows information about what we do, or who we're contacting, or how quickly we're responding, how long it's taking for us to close a case when someone contacts us. And then we were requested to note enhancements and future changes. So that's one of the topics there, number 8. And then we have an appendix for more of the detailed data that is not in the main thing. So our outreach is listed. This time around, I included our brochure in there, and then the managed care organization data. And that concludes the information that I'm providing. Oh, I did want to mention also that the annual report will be available in March. And if you would like me to, I can email it to your contact so it can be sent out to your committee members. And with that, I'd be happy to answer any questions you have.
Thank you very much for that update. And yes, I think we would take advantage of that. You emailing that report to Marisa so she could get it out to the committee members on that. Committee, do we have questions for the conferee? Senator Gossage.
Thank you, Mr. Chair. Carrie, thank you so much for being here. Because I help people with their Medicare, many of them are very confused about dual eligibility with Medicaid and Medicare. And the concern that I have is how many people fall in and out of that. It seems like, oh, I just got a letter that I've been approved, and oh, now I'm not. Now what do I do? And are you the person to have them contact, or who is the best person?
If they're confused about why they got dropped, or they don't understand their letter, any of those kinds of things, they definitely can contact our office.
All right. And last question, is there ever a time when a husband would qualify and the wife would not, or vice versa when they're under the same income?
It depends on what they're applying for. If it's just straight Medicaid, now I'm not an eligibility expert, so bear that in mind, but typically they look at household income. Right. And so if just for straight Medicaid, they would be looking at both of their incomes.
So you
Now-
would be the person that I could refer, or your office would be the best place for them to be referred?
Yeah.
Great. Thank you. I didn't want to keep this for an anecdotal question, but yet you see these questions all the time. Thank you for your help.
Sure. You're welcome.
Thank you, Mr. Chair.
Committee, do we have any further questions for the conferee? Representative Concanon.
Thank you, Mr. Chairman. Carrie, on page 4 of the report, you have a comparison of the KanCare, the clearinghouse contacts and your contacts. There's a huge drop off between the first quarter and the second quarter. And I was wondering if that was COVID related or if there's.
Oh, definitely. No, it was definitely COVID related.
Okay, why would that impact the contacts for?
You know, I'm not sure why, but I can tell you anecdotally that we are not the only 2 organizations that have reported this. I've been in other meetings and other people have said the same thing. The call volume is down. So for whatever reason, they're not contacting. Well, and you know, part of the reason may be because, but I don't think it's all of the reason. When COVID went into place, there was the KanCare eligibility was required to not drop anybody from KanCare during this time frame. So you can see that the bottom line, the bottom line numbers of KanCare, well, it's in my data by region report. It shows the KanCare clearinghouse or KanCare numbers by region, and it gives you a total. Those numbers are going up because there's no one being dropped for various reasons. Their income has increased. They had a renewal and they had problems getting their renewal in on time. There's that kind of thing happens, and so there are calls made to try and resolve those things. But when there's no changes and nothing's going on, and people are staying in home and trying to not do things, I'm just guessing, this is my educated guess, this is what I think is causing some of that decrease.
Yeah, that makes sense. I hadn't thought of that. Mr. Chair, can I have one more? And then on page, I believe I'm on page 7. Yeah, page 7 with your outreach. Those numbers really fluctuate from quarter to quarter, and just real curious about that too.
Well, and we have assistance with our outreach with our Wichita State contract. They provide a lot of help with that. And then we also use AmeriCorps Vista volunteers to do that. And so some of that has to do with our staffing, whether we have an AmeriCorps Vista available to help us with that. There have been times, third and fourth quarter of 2019, we did not have a project coordinator. That's the supervisor over our Wichita office. And they're the ones that get AmeriCorps Vistas there and do some of the outreach. We did have an AmeriCorps Vista there during that time frame, and she was doing the training of the new project coordinator down there. And then it was a time for that new project coordinator to get her feet under her. And you'll see that there was a big jump. Well, in fourth quarter, she was doing a game plan of what are we going to do for outreach and figuring that out. And then she went ahead in first quarter and did what she had been planning. So yeah, it can jump around a little bit. We don't like those numbers to be that low because we want to be making sure we're letting people out in the community know what's going on, but sometimes it can't be helped.
Okay, thank you. Thank you, Mr. Chair.
Oh, I will add that the person who was doing the training of the new project coordinator is who we hired as a volunteer coordinator. She did a great job while there wasn't someone in the office.
Committee members, do we have any further questions? Not seeing any. Carrie, thank you very much for your testimony and committee. We will now direct
Thank
your
you.
attention to written-only testimony from Jay Emler, Deputy Attorney General in the Chief Information Security Office for the Attorney General. He was not able to attend this morning, but he did provide written-only testimony. Committee members, we are through with our morning session and we are getting ready to break for lunch. We are a little bit ahead of schedule, but we will go ahead and break for lunch, and please be back at 1:30. We are going to start at 1:30 or 12:30. Yes, thank you. 12:30. Yeah. Thank you, Marisa. Yeah. So we are going to start promptly at 12:30. So if you guys could all be back at 12:30, we will see you then. Have a good lunch. Thank you. If you're listening online, give us just a couple of seconds and we'll be back up and ready to go. Marisa, you want to go ahead and begin with the explanation of the issues?
Okay. Good afternoon, committee. Marisa Bayless, KLRD. The item agenda we have right now is a review of the issue spreadsheet from Bethel. For some of our newer members, I just wanted to give an explanation of what this is. You should have it emailed to you. It's also available on the link for the website under the Bob Bethel Committee, but it will look like this. It's a longer spreadsheet with some color on it. And what we do for this is that after every Bob Bethel meeting, KLRD reviews all the testimony by the conferees that you heard this morning and later this afternoon. We try and compile some of the main themes or issues that were brought up within those conferees' testimony. So we create those specific issues or general issues on the left side, and then we have all of our managed care organizations as well as KDHE and KDADS then respond to it. So it might be a little bit difficult to follow here right now because we are going to be, for some of our newer members, because we are going to be reviewing those new issues from December. But as we kind of go through, you'll kind of see what we're talking about. From some of our veteran members, you'll be happy to know that we only have one spreadsheet that we are working with now. So thank you to the agencies and the MCOs for working with me on this new concept to try and not have 4 or 5 different spreadsheets going at the same time. So I just wanted to give a quick explanation of what this was before KDHE, KDADS, and the rest of the MCOs begin. So if you have any questions, please let me know.
Committee members, do we have any questions for Marisa?
It will not be on separate documents this time, so they'll all be in one spreadsheet. I sent an email out this afternoon, and then it's also available on the website. It will be titled KLRD Bethel Issue Spreadsheet.
Yeah, committee members, it was number 1 for me on mine.
We are going to be working from this document. It should be online, and then I emailed it to the committee members as well.
All right, do we have any other questions for Marisa? All right.
This is Senator Petty.
Senator Petty, go ahead.
I just wanted to, so it is the spreadsheet is specific issue resolution for 2021?
So that will be, yeah, the first page of the document that they'll be working on, KDHE, KDADS, and the MCOs.
Thank you.
And I plan on sharing it on my screen so those on WebEx can see it too.
All right, do we have any more questions for Marisa? Okay, seeing none, we will move on to Sarah Fertig, the Medicaid Director for the Kansas Department of Health and Environment. Sarah, welcome to the committee.
Hi. Thank you, Mr. Chairman, and good afternoon, members of the committee, and welcome to new members of the Bethel Committee. I look forward to working with you. I'll give Marisa a moment to pull it up. Here we go. All righty. And I would just like to say, Mr. Chairman, that I think Marisa's efforts to combine all of these spreadsheets into one will be really, really helpful for the committee going forward. So I for one, am a big fan of this approach. I think it makes it a lot easier to keep track. So KDHE was asked to respond to the only issue on the specific issues log. There was a conferee in December who expressed some frustration with a billing dispute that they had with one particular MCO. And KDHE's response for this, the conferee reached out to us separately in December of 2020 and asked for our assistance in resolving this billing dispute. However, KDHE does not have the legal authority, and neither does the MCO, to do anything to help this particular conferee resolve the billing dispute. So that would be our update on this, that neither KDHE nor the MCO has the legal authority to take the action that the conferee is requesting. And Mr. Chairman, as you prefer, I can either pause for a question after each one, or I can keep going and welcome any questions that come in while we're going through these.
If it's okay with you, Sarah, we'll wait until the end and hold for questions.
Happy to. Thank you very much. So that was the only issue on the specific issues log. Moving on to the general issues log. The first item that I'm going to comment on is issues item number 2, which Marissa has pulled up. And this is a concern that was first raised in 2019 concerning the former MCO AmeriGroup. AmeriGroup ceased to be a Medicaid MCO at the end of 2018, December 31st, 2018. And there were some issues with some outstanding claims that extended into 2019 and 2020. We don't have any additional update for this. At this point, all the time frames for providers to file claims and the appeals process, those have all run. And there really isn't anything more that the state or the MCOs could do, or the providers could do at this point to move this agenda item forward. So I would ask if we could perhaps close this item from the issues log, because there's nothing more that can be done at this point.
Sarah, I apologize. I'm going to break from what I originally said earlier, because I heard a lot of rumblings, and not only in my head, but from committee members. $14.3 million seems like an awful lot of unpaid claims just to walk away from.
Those were, Mr. Chairman, those were accounts receivable as estimated by the hospitals. And you'll see in our December 2020 update on that line item, a year later, that amount had dwindled to 4.1 million in accounts receivable. That doesn't necessarily mean, that's what the hospital thought that they were owed. That doesn't necessarily mean the amount that was actually owed. So those amounts had continued to dwindle, and we continued monitoring any outstanding disputes with AmeriGroup. And currently there are 3 remaining provider disputes that are going through the administrative hearing process.
Sarah, thank you for that explanation. Sarah, if we could hold one more second. Representative Carpenter had a question on that.
I just might elaborate on that from one that raised quite a bit about this. And what happened, the biggest probably thing was that they had a bond, a $5 million bond, but our time frame, and it has not been changed, was like 18 months. And it was to clear this up, and all these claims came in, after that fact. We already sent them back their $5 million bond, and we were stuck with this deal. And I think hopefully by the time we have another MCO exit our state, hopefully we never do actually, but that we put something in place that keeps that bond for a longer period of time so that we can protect our providers. So just FYI.
Thank you, Representative. Sarah, you can continue.
Thank you, Mr. Chairman. The next item up for KDHE is number 6. And this is an issue that Mike Burgess from the DRC, he wanted an update on the behavioral health employment support pilot that KDHE is working on. We are still on track for a July 1, 2021 rollout. And Mr. Chairman, if it's okay with you, this is part of our standing update to the Bethell Committee, and in a short while, I'm going to give more information about the status of this pilot. So this is another item that I would suggest that we close from the log, because we regularly update the Bethell Committee on this particular item during our agency presentation after the log. If you like, Mr. Chair, I can keep going. The next item for KDHE is item number 7, which is right below. And this concerns community service coordination. This project has been on hold for some time. It is still on hold, so we don't have any further update on that currently. The next item that KDHE will speak to, let's switch to my page, is item number 13. And you heard some testimony earlier today about increasing the protected income limit. And our update for the Bethel Committee this time is that the regulation that would codify the protected income limit increase to $1,177 a month, that became effective on January 1, 2021. So at this point, there's really nothing else that KDHE or KDADS or the MCOs could do to address this particular item since that regulation became effective. Moving on, the next item for us is, let's see. I think Marisa's ahead of me. I think item number 26. Thank you, Marisa. And this particular item concerned a need to increase benefits planners for Kansans with disabilities. I am very pleased to report that we have hired 2 new benefits planners, and they started work earlier in the month. So we're pleased to announce that. And if the committee wishes to continue to monitor this comment, we can. Otherwise, we have addressed Mr. Burgess's concern, and we would suggest that perhaps this item could be closed. The next item for KDHE's response is item number, let's see. Actually, Marisa, could we back up to 34? Thank you so much. On this particular item, I just had a comment. There was a concern expressed in the June Bethel meeting that the COVID relief bill that was signed during the special session did not include a liability shield for nursing homes. And the conferee asked the state to do something about that. There's really nothing that KDHE can do to address that. This is something that would require legislative action. And I believe there's actually a bill being considered now that would just do that very thing. So I would suggest that we close item 34 because there's really nothing that any state agency can do to address that conferee's concern. And so Marisa, we can move on. Thank you so much. Okay. So moving back to item number 45. This came from the December Bethel meeting. There were some concerns about vaccine rollout, and our response here is that the state, KDHE, has created a vaccine-specific website that has information about phases and also has a Where's My Vaccine feature so that anyone can go in and try and figure out where a vaccine might be available in their region. And we provided the website for that website there. And I would add that later on this afternoon, I believe Dr. Norman's going to give some information about vaccines. Moving on, the next item for KDHE's response was item number 47. This came to us from the Kansas Hospital Association. They're requesting that we increase our reimbursement rates for providers who administer the COVID-19 vaccine. And it's been suggested that we pay Medicare rates for that. And our response is that currently we just lack the funds to do that. Our data team has looked into what it would cost above what we're already paying for COVID-19 vaccine administration, and to pay Medicare rates, assuming a 90% vaccination rate across all Medicaid beneficiaries, that would cost us a little under $3 million, and we just simply do not have those funds right now. I would add, however, that we're aware and are tracking some proposals at the federal level that would increase the federal matching percentage for COVID vaccine administration rates. It could go up to 100%. And if we do have the opportunity to draw down additional federal funding to help buffer that financial impact, we will certainly revisit this. But for now, our reimbursement rates for COVID-19 vaccine administration are going to be the same as our other vaccines. And I believe, Mr. Chairman, that that was the last item requiring KDHE's response. I'd be happy to stand for any questions the committee might have.
Committee members, do we have any questions for Sarah? Sarah, I would like to go back to 45 on the vaccination thing that you said we should probably close. I know in testimony this morning that was still kind of an issue. Should we keep that on there and add that to it, or just close this one and add a new one?
Oh, number 45, Mr. Chairman, I think it's fully appropriate to keep that on there because there will continue to be updates as the vaccine rolls out. So I think that's okay.
Thank you. Committee members, do we have any other questions for Sarah? Okay. Not seeing any. Sarah, thank you very much.
Thank you, Mr. Chairman.
Committee, next we will turn our attention to Janice DeBeer. She's the Deputy Secretary of Programs for the Kansas Department of Aging and Disability Services. Janice, welcome to the committee.
Hi, thank you, Mr. Chairman. I appreciate your time today, and I echo Sarah's comments. We can't thank Marissa enough for helping us with this spreadsheet. It really was incredibly efficient this particular time around. So what we have done is we've provided Marissa with our top 10 list, if you will, our top 10 issues. So that's not to say we aren't more than happy to respond to any questions for other issues on this chart. But for us, we wanted to make sure we highlighted these top 10, and we start with number 1. And number 1 is a lot of discussion surrounding the IDD waiting list, which you are all very familiar with, as are we. We do want to report to you that from our vantage point, the IDD waiting list in particular is a two-pronged, could lend itself to a two-pronged approach. And the first prong would be, let's review the actual needs of the individuals on the IDD waiting list. That has not been done for a while. We do agree with Matt Fletcher and other stakeholders that you heard from this morning that an evaluation needs to be done. We agree, we concur, and we did meet. Amy Penrod, our commissioner, met with a group earlier this week, reviewed what it might entail to actually do a very deliberate and intentional study, if you will, of the individuals waiting on the IDD waiting list. That seems that it would be the first step toward developing a plan that Matt Fletcher requests here to actually determine how Kansas might, at some point in time, reduce and eliminate the waiting list. So that is our update on issue number 1. Our next item is number 8. And on this particular item, we were asked to address how this item could be closed. From our vantage point, we just wanted to share with the committee members that this issue is that SED waiver customers should be able to transition to the IDD waiver without needing to wait on the list, which would mean these individuals would be in front of the 4,500 individuals that are currently waiting. This is one of those, what I would call, unique issues that we simply do not agree with this particular conferee, and at this point in time, we haven't taken additional steps, but I would respectfully ask that this issue be removed from the log sheet, but obviously that's your prerogative. Our next issue is number 21. Okay, this issue came from Mitzi McFetridge before she retired in December, and we wish her well. That long-term care facilities had been taken into receivership, and we agree with Mitzi on that, as you all know, and you'll hear later today in our testimony that 22 facilities were in receivership status in the last couple of years. I am pleased to report early that there is only one facility that has not been sold. The other facilities have all been purchased and are not in receivership. Mitzi's point is that the agency needs to do more when it comes to applications that we review. Again, I'll just thank you for the action you did take 2 sessions ago to help us strengthen the receivership statute. You did that for us very quickly, and it has proven to be helpful. Now, that's not to say that the impact of COVID isn't real. And you heard from Haley earlier this morning that facilities, I think Rachel maybe mentioned this too, and maybe even Linda, that these are unprecedented times for nursing facilities as far as their financial stability. So we take this issue seriously, very seriously, but we are pleased to report that we only have 1 facility left in receivership. And then we hope that as we move through 2021 and move into 2022 post-pandemic, that we will be able to help facilities stabilize as best we can with your help. Number 22, Haley brought up in November, the peak process. We just wanted to provide you with an update. We have taken a couple action steps on this one. We reported in December that the peak process is being revisited. Then in February, we did have a presentation made by the peak work group, and they did a really nice job of sharing with us their recommendations. And that work group, we have KDAD's folks involved, we have KSU folks involved, we have an entire advisory panel that we've got involved in this particular initiative to just revisit peak in general. It's been around for a long time, but it has been it has evolved over the years, but I'm not sure it's meeting the goals that we had initially intended. We recognize that, so we appreciate Haley's comments, and we appreciate the work that's being done by this work group, this new work group, if you will. It's pretty impressive what they've done, actually. On issues number 31. Oh, this was from Matt Fletcher, and the fact that it took a really long time for retainer payments to be processed in Kansas, and it did. But we are pleased to report that the MCOs did process approximately 1.2 million in retainer payments to qualified providers in December of 2020. So we would request that this issue be removed from the log sheet. It is completed. Something to think about. Number 33. I think that's still 32. There we go. So number 33, PPE to clients and their direct. Oh, you know what, Marissa, I forgot 32. I'm sorry, you were correct. I'm sorry, you were right. So on number 32, this was a lot of conversation regarding PPE and what we were doing for nursing facilities. You have attached to your email a document that we're calling the Super Tracker. We shared it with you at the last meeting, and we've shared it again. It hasn't changed significantly, but it has changed some. It's a 20+ page report that shows you by your counties all the facilities that received Spark and CARE dollars, and much, or I should say some of that Spark and CARE dollars was in the form of PPE sent to adult care homes across the state. And you have that updated sheet. There was over 18.2 million that was provided from the recovery office for PPE to adult care homes. So we are pleased to report that we are just about ready to wrap up with that effort. The last $530,000 will be sent to adult care homes. We will send them hand sanitizer and other items that we believe will be beneficial as we continue to work through the COVID-19. But more than anything, we just want to share with you this particular spreadsheet, not this issues log sheet per se, but this separate Super Tracker spreadsheet from KDAD's that shows you how PPE was distributed across the adult care homes in Kansas. Number 33. This is PPE to the community-based providers. We heard from the community-based providers, and we agreed with them completely that although they were not mentioned in House Bill 2018, they too needed assistance with PPE. So thanks to I'll again give credit to Scott Bruner. Thanks to Scott standing up this portal through Source 309, we were able to coordinate with our community-based providers, the Centers for Independent Living in particular, to get some PPE sent to them. They received just under 1.4 million in PPE, and I will share with you, if you haven't heard some of their stories as far as the distribution, please, you'll want to reach out to your Centers for Independent Living. In addition to that, we were also able, through Source 309 in the portal, we were able to gain access to iPads, to what am I trying to say? Oh, refurbished iPads. So we sent out over, I believe we ended up sending out well over 2,000 iPads across to our community-based providers. In fact, it was closer to 3,000 iPads, well, maybe more than that we were able to send out to our community-based providers. That include the area agencies on aging, the Centers for Independent Living. We sent over 2,000 iPads to InterHab and the CDDOs. We sent iPads to the CMHCs so that they could get these communication devices out to their consumers, so that we could make sure these individuals could link to their medical provider and their families, to be perfectly honest, that they could stay connected during this pandemic. That ended up costing us, I think, just over $1 million. So we are very pleased. We would also ask that this item be removed as it is complete from our vantage point. And then the next one is 35. And this is probably where we might need to rely on Scott Bruner this afternoon. Scott is going to include this discussion in his presentation this afternoon, where Mitzi McFatridge was concerned that with infection control practices in nursing facilities, and I think Scott can do a better job than I can in explaining, what our survey team did as far as follow-up and complaint investigations for infection control concerns throughout the pandemic. And he can also talk about visitation, but we have captured Scott's comments here, and he will share more with the entire committee later this afternoon. And then our last item that we wanted to spotlight as our top 10 is number 37. The Money Follows the Person program. I suspect several of you are familiar with it. The concept is that money would actually follow a person out of an institution and into the community setting. Kansas has actually been a leader in this area for years. We've lost some ground, we've lost some footing, but we believe we may be well positioned once again in working with our federal partners. And I'll tell you, we can't thank the advocates enough for this. Amy Heighton and others with the Centers for Independent Living have really worked hard at the federal level to get this MF program reinstated at the level. Then our team, Amy Penrod and her team, have worked really hard to get Kansas reconnected. So we are working with our stakeholders to design a new program. If the federal grant is received in Kansas, we want to hit the ground running and get a MFP program up and going again. And we very much appreciate, again, the leadership that our stakeholders have provided to us to get this MFP going again. So with that, Mr. Chairman, that is our top 10 list. If there are other items you would like for me to address, I will be happy to do so. But these are the items from our vantage point that we've taken action on since our meeting in December. And I'll be happy to stand for any questions.
Janice, thank you. Committee members, do we have any questions for KDADS? Janice, not seeing any. I think we will move on. Thank you very much.
Thank you.
I guess just a quick question for Marisa and maybe for the committee as well. the items that they wanted to close, both KDADS and KDHE. Is that something we need to take action on, or?
The committee doesn't need to take action on it. I've noted when they've requested to, and I can redo the spreadsheet and have you and the committee review it after, if that works.
Yeah, that works for me.
Okay.
Chairman
Representative
Hildebrand?
Ballard. Yes.
On closing or opening items, what I've done in the past is if you feel comfortable in closing them, you say we can consider them closed. Is there any objection? And then you're done. So that's just the way that I did it. You don't have to do it that way.
Okay. Thank you, Representative Landwehr. Representative Ballard.
Thank you, Mr. Chairman. Representative Landwehr just made the comment that I was going to make, how we had done it. But the other thing is, those two, I'm just trying to remember. I know it was 33, but what was the other number? You wanted to 30?
For KDADS, it was 33 and 31.
31, okay.
And yeah, KDHE had a few too, and I've noted them as well.
Well, committee members, if there are no objections to closing those, we'll have Marisa put that out for us to final review and consider those closed. Okay. Representative Concanon.
Thank you, Mr. Chairman. To dig through here. The one about transferring on the from the one waiting list to other from services to the other services. Sorry, I can't hear you. I'm trying to find it.
Number 8. Number 8, I suspect you're referring to number 8, Representative Concanon, transitioning from the SED waiver to the IDD waiting list. Is that what you're saying?
Yeah. So yes, thank you, Janice. I think that one I would like to look back at Roxanne's testimony to see why she was. I'd like to see her argument on why that should happen. I think that because KDADS disagree is not just disagrees with it is not a reason just to take it off. So I'd like to look at that one just a little bit longer.
Sure, and Marisa can get that all.
Thank you, Mr. Chairman.
Set up for us. Thank you. Any other concerns on any of those closing? Okay. We will now move to our next order. Just a clarification. There were no objections to any of the other ones closing except for number 8. And then we're going to review with the Roxanne's testimony versus KDAD's and then make a determination afterwards. Okay. So moving on, our next conferee is Secretary Lee Norman, KDHE.
I think we skipped one section, the 1 p.m. updates from the managed care organizations.
You are correct. Thank you. Sorry about that. We are going to back up to our regularly scheduled program, and we have updates for our managed care organizations. First up, we have David Livingston, CEO of Aetna Better Health. David, welcome to the committee.
Thank you, Mr. Chair, members of the committee, and I'm pretty sure the MCOs will move through these pretty quickly, so we'll be able to jump to the next agenda item. So our first one is number 1 on the specific issues resolution, and this is in regarding to the issues with clearinghouses, and certainly Director Fertig addressed the legal authority. But certainly, Aetna, if a claim is held up at a clearinghouse for a reason that's outside of the provider's control, we do ask that the clearinghouse send us the file with the original receipt date when applying our timely filing policy. So we definitely have flexibility, and it's our policy to review any external issues that would impact the timeliness of a clean claim and review that with the provider. So our next one, I think, is item 25. In this regard is regarding reimbursement, and our response is the same as it has been, that, you know, if there are any fee schedule increases, we would certainly pass these through to our contracted providers. Then the last one we have is item 46, and I have to apologize. My team doesn't normally let me cut and paste, and I cut and paste the wrong response here. So I apologize for that. I have sent Marisa the correct information, and I will actually share with everyone the correct response. So this had three parts. One had to do with prior authorization. We have throughout the pandemic and continue to waive pre-cert prior auth requirements for SNF admissions. We do this to assist our hospital partners in moving patients to post-acute care, so that we can make sure that we are engaged in the case management for these members. We do require the post-acute facility to make us aware of the admission within 48 hours and to provide clinical records within 3 days of the admission. We are working very proactively with the departments at all of our partner hospitals to identify any post-acute care facilities that have capacity to accept the patient, and we will contract with those facilities either on a full contract basis or a case-specific basis to make sure that the member is taken care of. And we continue to work with our hospital partners to evaluate any processes, and we are working very hard to make sure that we eliminate any friction during this pandemic. The second point that was brought up was post-pay review of high-dollar claims. Prior to January of 21, we had not done any of this post-pay review, but we did start this, and at the recommendation of the Hospital Association, we are going to update our process to ensure that COVID-19 admissions are removed from this review process. And the third issue brought up had to do with COVID-19 vaccine education and timely filing. We publish both all KMAP and Aetna policies on our public website. Additionally, we have an email list server that we forward these policies to any provider who has signed up. Our provider relations team, both those out in the field every day, as well as those our phone-based team, have been educated on all of our COVID-19 vaccine policies, and we are always working to make sure that we assist proactively and provide answers to any questions that providers might have. And that concludes our responses.
David, thank you for that. And committee, do we have questions for Aetna? Senator Gossage.
Thank you, Mr. Chair. And thank you for being here, David. Just a quick question. Could you please tell us what the acronym SMC stands for?
Oh, I'm sorry, which one?
It's the SMC rate, $47. I don't know what SMC stands for. It's on number 25. Number 25?
Right. So I would...
It is. This is Marisa from KLRD. It's specialized medical care. And on the spreadsheet at the very back will be a glossary of acronyms that we use in Bethel. So I meant to say that, but forgot about that.
That's all right. And thank you, Representative Concanon, for bringing that over to me. Thank you very much, and thank you, Mr. Chair.
Do we have any more questions for David? Okay, not seeing any more. David, thank you very much for providing that information for us. Next up, we have Michael Stevens, President and CEO of Sunflower Health Plan. Michael, welcome to the committee.
Thank you very much, Mr. Chairman, and it's my pleasure to be here. We have the same 3 items on our list to respond to and really have nothing additional to offer besides what has already been mentioned both by Mr. Livingston and by Sarah Fertig. I would just say that we do continue to work through all claims to make sure that our processes follow state policy and that providers have ample opportunity to clean up and correct claims. That's issue number 1. Issue number 25 regarding the specialized medical care. Again, we continue to work collaboratively with the other 2 MCOs and with KDHE and KDADS to try to have adequate reimbursement rates that would make sure that the needs of our members are met. And this is a continuing issue that we all work on. And then item number 46, again, this issue was actually originally raised in March of last year. And all 3 MCOs, along with KDHE and KDADS, have continued to collaborate with the Hospital Association to facilitate claims payment with the minimum amount of frustration and abrasion during that time. And I have no other items on which to report. Thank you.
Michael, thank you. Committee members, do we have any questions for Michael? Okay, not seeing any. Michael, again, thank you. And we will move on to Carrie Kimes. She's the Director of KanCare Relations and Strategy for United Healthcare Community Plan. Carrie, welcome to the committee.
Hi, thank you so much, and good afternoon. Similar to my MCO partners, we have updates on 3 items this afternoon. Item 1 on the specific issue resolution in relation to claims coming in through clearinghouses. Just a couple of notes in addition to what's been shared up to this point is just to remember that as claims are coming in and being considered for processing, we do have to make sure from a program integrity perspective that we have the right member, date of birth, the Medicaid ID, and all of that matches up so that we're being good stewards of the state money and making sure we're paying to the right member. And so it is critical that that information come in correctly on a clean claim so we can make sure we're paying those accurately. That's why the MCOs in all of our contracts have a pretty healthy time frame of 365 days for providers to make corrections when that happens so they can get those claims back in. And as always, we try to work with providers during that 365-day time period to make sure they understand how to get those corrections made so their claims can get through the process. Our second item, similar to the other 2, is item 25 on page 19 in regards to the rate increase for specialized medical care. We support this, and any provider rate increase for that waiver code, we would implement that as soon as it's approved through either the legislative and or state process and get that out to our participating providers, similar to the other MCOs. And then finally on number 46, page 33, the items from the Kansas Hospital Association. Again, kind of split into 3 separate questions. First one was regarding prior authorization. We continue to ask providers to let us know when they admit one of our members, but we've removed any need for them to submit clinical documentation or additional records when it's a COVID-19 admission. There was also a mention that there was a policy that would restrict payment to a post-acute care facility to 3 days, and we did confirm and share with providers that there is no such restriction. If the member meets the basic criteria to have a post-acute stay admission, those members are allowed to be admitted to those facilities for care. The second part of that was regarding suspension of post-pay high dollar claim reviews. United did suspend those high dollar post-pay claim reviews during the month of December and January for all reasons for all Kansas hospitals when we saw COVID-19 cases at their highest and new providers were really focused on dealing with that. These post-pay audits will be initiated again late February, although COVID-19 admissions are being excluded from those post-pay reviews. And then finally, similar to the other 2 MCOs, as it relates to information about the COVID-19 vaccines and other COVID-19 treatments and testing, we get that information out to providers just as quickly as we can. As soon as we get those approved policy documents and approved bulletins, we generally can get those out to providers via a number of channels within 24 to 48 hours, so they have the most current information. And that is all I have to share with you today. I thank you for your time, and we'll answer any questions.
Carrie, thank you for that. And committee members, do we have any questions for Carrie on their resolutions? Okay, not seeing any. Carrie, thank you very much. Now, committee, we are ready for Mr. Secretary Lee Norman with KDHE. Mr. Secretary, welcome to the committee.
Thank you, Mr. Chairman, and thank you, committee members. I appreciate the opportunity, my staff and I, to present to you today. This has been a challenging time, no question about it. When you think about a crisis, usually there's a nice beginning to it, it peaks out, and then it gradually fades away, like a tornado or even a flood, for example. But this is one of the, I think, a unique crisis, certainly during our lifetime. And it's really many different waves of a crisis. And when I think back, and I heard Ms. DeBruce talking about PPE and infection control, I'm reminded that the many waves during this committee include PPE. Remember when we didn't have enough of that, and we gradually got more and sufficient to meet the needs of our state. Remember testing. We were chronically low on the testing platforms and chemical reagents to do testing. And now we are, I would say, as a state, flush in the ability to do testing. Matter of fact, we've gotten up to between 2 and 3 million Kansans tested at this point. Case investigators, contact tracers were in very short supply. We've had to bring on many people to assist with that. Hospital beds were in short supply, and most certainly staffing was in short supply because we had so many people out that were ill, isolation and quarantine. Therapeutics, you've heard about the things that we give people, particularly nursing home patients and outpatients, to keep them from getting ill and required hospitalizations. And Kansas has been a star of all the states. Matter of fact, the Health and Human Services chair on the Trump administration, Alex Azar, called and said, "What are you guys doing in Kansas?" Because of the bamlanivimab and the Regeneron, you may remember those when the president was ill, have been used in great supply, particularly in middle-sized rural and critical access hospitals, and really helped to decompress the clinical activity in hospitals. It really kept our hospitals from getting overrun, I think. And finally, mission control. One of the things we've always looked at this, whether it's in the Medicaid program or our healthcare in general, what is it that we can learn and experience by way of this pandemic in the state of Kansas and come out of it on the other end actually better off? And one of the things that became apparent very early was that when rural hospitals particularly had somebody that was too ill to be cared for there, they found themselves in the position of having to work, make 8-10 phone calls, trying to match up a patient and their needs with a bed in a referral facility. And it could take a good part of a day just to even find that. One of the things we've done is put together, and you see it down toward the bottom of this brief listing of topics that I'm talking about. Mission control using Cheyenne Mountain software is a one-call solution, particularly for emergency department nurses or physicians and the like, where they can make one call with what does the patient need, and then they get to hang up, go take care of the patient, and then they get a call back that said, okay, not only do we have your bed lined up for this patient, but we've got transportation arranged, so you don't have to do that. This will continue after the pandemic is over. And then finally, vaccine. And this is a front and center now. And again, in this continued theme of shortages, we are obviously still short on vaccine. I'd like to make a few comments about that. And that is, one, we have been getting the vaccine that the state of Kansas is allocated by the federal government. We are approximately 1% of the population, and we've gotten everything that we've asked for. In other words, our full allocation, which has been really critically important. So overall, I'm pleased to report that Kansas is getting better. The cases per capita are dropping. The death rate per capita is dropping. We still have lots of cases coming in and still have deaths occurring. So we still have lots of work to do, lots of vaccines to give. But both of those metrics, which are quite important, are getting better. The one that is really quite improved is the testing positivity rate. You'll recall we were as high as 16, 17% of the tests that were being done were positive. I looked at on our dashboard today, as a state, we're 5.3%, and some of the counties are below 5% positivity rate. We haven't seen those since the last 8 or 9 months. So those things are going the right direction nicely. This has been a very gratifying time in one regards, working with our sister agencies such as KDADS and the Kansas Division of Emergency Management, and most certainly working with the MCOs. You see about the infection prevention in beneficiaries and caregivers. We've had to make a lot of adjustments because of the vulnerable populations in those respective areas to keep the client, the beneficiaries, and the staff safe. And things like that creativity and televisits that have been implemented have been extremely helpful. And I will say that the MPOs, and I think our agencies as well, have done a lot of out-of-the-box thinking, which has been very gratifying. Talk briefly about vaccine delivery and use. This is obviously going to be the biggest game changer. When I talk to hospitals, this has been a huge game changer because they have their staff back. There were hospitals that I dealt with that had 80 to 90, 100 people out, and now have low single-digit number of people out because of isolation, quarantine, illnesses, or even death of the staff members. The vaccine, we've given over 418,000 doses of the vaccine. We've been allocated 581,000 doses of the vaccine for a 72% administration rate, and between 10 and 11% of Kansans at this point have been vaccinated. If you go to in the interest of full transparency, if you go to the CDC tracker website, it shows us fairly low in the terms of the per capita administration rate. And part of the problem is that we have about 1,400 different registered vaccinating sites now. We have a huge capacity. We can take a lot of additional vaccine coming in, but with the expansion, one of the things that we have found in terms of the vaccinating sites is that the electronic records aren't talking to our vaccine tracking program. Starting on Monday, we've been working with the various organizations because we need to clean that data up. I can assure you that the 72% reported is a low number. We are actually much higher than that, and I think that data will get cleaned up very quickly. The vaccine that's going out is getting injected into people's arms. There's a little bit of inventory while people, for example, get through this week of bad weather. A lot of the vaccination clinics had to be canceled. Another nuance is that we didn't get it. We might have gotten some today, I'm not sure, into the state of Kansas, but we didn't get any vaccine coming in because of Kalamazoo, Michigan, and Memphis with UPS and FedEx. We're not flying. So we will we'll show a blip where we don't have as much vaccination going on this week, but hopefully we'll be able to pick that up in the next week or two. I commented on the testing, expansion, and management results. Been pretty gratifying. Starting in November, we got from the Recovery Office, CARES Act relief money that we've been able to expand and have stood up many different brand new testing sites around the state. A very productive partnership with Wichita State with some commercial labs, and a dramatic uptick in the amount of testing we've been able to do. The novel therapeutics, those are those long words I mentioned, bamlanivimab and Regeneron, the antibodies that are infused into people. We've very strong performance with that. The feds are not going to give it to us free anymore. We've been getting, matter of fact, shipments from the federal government, and also because other states haven't used it as much, we've gotten it redirected from other states to us. And but now it'll be on the hospitals and clinics and nursing facilities to purchase it starting as soon as we go through our remaining inventory of that. Hospital capacity, I'm really glad that we made some good decisions back in April and May. We didn't build extra hospital beds. We didn't stand up tents because we knew that the shortage was going to be in staffing. And I'm glad that we didn't spend tens of millions of dollars building fixed wall facilities like some states did. They sat empty for the most part, and I'm glad we didn't choose to go that way. Hospitals are in great shape, from critical access all the way up to the tertiary quaternary care hospitals are in great shape right now. They're very happy. Hospital Association and my agency have worked very closely together with the hospitals. We're on calls every week and taking their pulse and seeing what we can do. And it's been very productive. Control, I mentioned, that's the patient referral and transfer program. And then finally, one of the things that's going to help us terrifically in the last bullet here is the retail and long-term care pharmacy programs. We're getting about 45,000 doses of the vaccine from the two vaccines, Pfizer and Moderna. We think that Johnson & Johnson is going to come online in the not too distant future with a one-shot vaccine series. Hopefully within the next few weeks, that approval will come through the FDA. The retail pharmacy program is one where the federal government pushes directly out. This is new on the Biden administration, pushing it directly out to retail pharmacies. Yes, Walmart's, CVS's, and Walgreens and the larger ones, but also to the CPESN network. That is the consortium of smaller and independent pharmacies that oftentimes are the only pharmacies in many communities. And we're working very closely with them, and they work very closely with the county health departments, as do we. Long-term care pharmacy program, you may remember hearing that CVS and Walgreens manage that directly with the federal government, been very productive. Everybody that in the long-term care facilities that wants a dose has had their first dose. The challenge we had, quite honestly, was that the CMS regulated facilities in the, I think in the mid 600s, 650 or so, were the ones that we had good optics on. We could see those. It took a while for us to get the smaller or state inspected and licensed facilities, because that went through a different program, not the federal program. And I think we've really caught up with that a lot. We're essentially done with the first round, and now we're kind of doing cleanup with the second doses into all those kind of facilities. I might make one comment. I understand that in a session earlier today, there was a question about where do IDD persons fit into the vaccine prioritization plan. And we recognize that IDD is a very diverse population of people from young to old. Some people have underlying medical conditions, some don't. Some live in what we refer to as congregate settings, some don't. So what it's not as easy to say this just because they meet the definition of IDD that they are in X phase. And let me give you a couple examples. Phase one is the first phase. It was healthcare workers and long-term care residents and staff. An IDD person could be in a skilled nursing facility, for example, and therefore qualify in phase one. The more likely, if they're in congregate settings, and the term congregate setting is very specifically defined. Licensed congregate settings are facilities licensed by the state or local governments to provide housing or care arrangements where social distancing is not possible, and it goes on with a little bit longer definition than that. But there's a lot of groups that are considered congregate living. They are in phase two. It's the largest phase. It's a phase we're in right now. And we're moving right on through it. Back to my earlier comment about 45,000 doses a week was what we had. We're now over 100,000 doses a week. And but we're right at 1 million people in the state of Kansas in phase two. So it'll take a while to get through that phase. There could be some IDD individuals that are that don't meet either the phase one or phase two criteria that I mentioned, but have underlying medical illnesses. And they would be in the next phase, in phase three, depending on if they have whatever their age is, 16 to 100. They would be, if they have underlying medical illnesses, that qualify in phase three. So it depends, again, how dependent or not independent, what is the setting, what are their underlying health conditions and the like. And then there's a little bit of, judgment in terms of where they fall. We do a lot of adjudication to help the counties figure out where to place them in the cascading. And by the way, when we didn't just make this stuff up, the CDC and then the Advisory Committee on Immunization Practices advised the CDC and the states on these risk-based prioritization tiers, if you will. Ours looks very much like the CDC. We did also have our own unique state approach with a COVID-19 advisory committee, because one of the things that I did not want to have us go through in Kansas was just having it be us insiders making these decisions in isolation. So we had a very broad committee from, yes, clinicians, scientists, bioethicists, but also people that represent the associations. For IDD, for example, individuals, we had various populations of ethnic, racial mix, tribal communities, and the like. And they were very helpful. And not only were they helpful in coming up with the prioritization schedule, but we are keeping them engaged and going forward so that they'll keep us honest, quite honestly, with looking at the data, whether it's by ethnic or racial groups, by age groups, and so that we know that we're on target with who's getting the vaccine. And really the question, how are we doing? I'm going to turn it over here in just a minute, Mr. Chairman, and of course, unless you have any questions, to Sarah Fertig, our Medicaid Director, and Chris Schwartz, our Medicaid Chief Operating Officer. Huge kudos. Those of you that have been on the committee for a while, or those of you who read the newspaper, are well acquainted with the concerns we had about Maximus and how we took back certain portions of Maximus, and then now we have migrated completely away from the clearinghouse from Maximus involvement. A tip of the hat to these guys. This has not been easy working because some of the people can work from home and most cannot work from home because of the very sensitive nature of the and patient privacy. We want to make sure that nobody working remotely was dealing with sensitive patient information. So we've been mostly just working. We're today, matter of fact, to that point is this makes us 56th week, so over a year and a month in incident command, which is a 24/7, 365 battle rhythm to keep everything going. And I think a lot of credit to the MCOs and then the staff for running a very complicated KanCare program in the middle of a pandemic. So with that, Mr. Chair, I will, in my remarks, be happy to answer any questions that you have.
Thank you, Mr. Secretary. And before I open up for questions, I did have one for you. Earlier in testimony, we heard from some conferees talking about long-term care vaccinations. And I was reading an article just this morning from the New York Times. I don't know if you've read it or not, but it says, short of vaccines, states find hidden stashes in their own backyards. Millions of doses of coronavirus vaccine are still sitting in freezers, allocated in excess to nursing homes or stockpiled for later use. Now states are claiming them. Do you know if that's something in Kansas? Are you aware of that? And is that something Kansas is doing as well? And
Yes.
so how successful have we been on reclaiming those?
Absolutely. That's when I pointed out that there was 45,000 doses a week, a few weeks back, and now at 100. That's where some of that's coming from. And the reason is that the feds allocated to CVS and to Walgreens an amount of vaccine, hypothesizing that it would be, let's say, an 80% uptake by nursing home staff and residents. And yet it was kind of a best estimate from them. We have started getting back additional dosages from the nursing facilities, and it's coming back to us and we've been redistributing it out as it's come in. So it's absolutely spot on true. The other thing is that there's always a little bit of holding back because with both Pfizer and Moderna, the second dose is the same as the first dose. And we want to make sure that when somebody has had a first dose, that they absolutely get their second dose in a timely manner, 3 weeks for Pfizer or 4 weeks for Moderna. So we are getting back those. I don't know, I would really call it a stash. It's where it's been inventoried until they were sure that they could release it back to us, because we're going to push it right out and put it in people's arms.
Do you happen to have a number of vaccines that that the state of Kansas was able to reclaim or claim?
I don't have that at the tip of my tongue, but I know it's in the tens of thousands of doses. But I can certainly get you and the committee members that number from our immunization program, because we monitor and log every dose.
Thank you. I think that would be great.
Sure, happy to.
Representative Landwehr is online, and she has a question for you, Mr. Secretary. Representative Landwehr?
Thank you, Mr. Chairman. You know, we're still hearing issues with the delivery of the vaccines where we're finding that some of the rural areas are getting an overabundance, and then the urban areas then are still shorted. So the rural areas are out there trying to find anybody that they can that will take a vaccine. How do we start getting this under control so that we know that the right number of vaccines are going where they need to go?
Yeah, that's a great question, Representative Landwehr. And that's absolutely the case in a couple counties, and I can tell you which ones they are, who got relatively small numbers of doses, but for whatever reason have burned through those. I don't know if it's because they haven't had enough uptake by their county members or not. What we are doing is starting next week on going back and are starting them on an alternate week schedule, because the two counties that maybe you're referencing, one of the things we've seen is that we've tried to move Kansas through these phases 1 through 5 in somewhat in a synchronous manner. And what we have found is that in some of the rural counties, they're up to 25 doses delivered per 100 people in the county. We have a few other counties that are more down at the 15 to 18 doses per 100. So what we're doing is we're putting a pause on the ones that are up at the 25 per 100 and are redistributing it so that the counties that are lagging a little bit can catch up. And that starts next week.
Well, but, you know, we've been at this here a little bit for a while, so I'm just still frustrated that we don't have a handle on what our county's needs are and what they're doing. And I think it might be beneficial for us, and I have not talked to Chairman Hildebrand on this, but perhaps if we could get what is happening in our counties, maybe an update on a weekly basis, in kind of a written form, simple. We don't need 15, 20 pages of an explanation. And I think that would help all of us in dealing with our counties. So that's my 2 cents on that. Then the other issue that I have a concern with is with our testing. I see that where we are looking at, yes, at expanding that testing, but we're also doing that with a Boston company that's sending their tests to Texas. And I struggle with that, because I think we've got a lot of, places around the state that can help us with that. Down in my woods, we've got Wichita State who's ready to gear up, and they can add more equipment, if we need to do that. And one of the things I like about their testing that they're offering down there is a business or an organization can actually have employees get trained to provide the test. In less than 24 hours after they've picked it up, they get results. That's not happening with what's going on with our Boston company that's doing business here and the test in Texas.
Let me do a little course correction, ma'am. We have no testing being done outside of the state. 100% of the testing are done in Kansas laboratories. It was some of the tests were going to AIT, and the reason was it took our lab partners, MAUD, CRL, and Wichita State. It took them a while to build up the capacity to do that. So it was clearly second or third best to go to AIT in Texas. No question about it. The turnaround time was slow. Now we are entirely within the state of Kansas. As a matter of fact, the Boston Consulting Group doesn't have anything. They just have been doing some project management. They do not do any testing. They just helped us set up the test stations.
Well, I know that they're going around the state and looking for properties to set up these sites. And I believe is that Well Health or Well Care?
Well Health.
You actually contrast?
Yeah, they're a Texas company indeed that has helped us to set up. See, the trouble with testing, I should say the difficulty with testing, and we took this to WSU, we took it to our other lab partners in the state, is sampling. The samples don't, you have to sample from the person. Those labs that you mentioned and that I've mentioned do not do sampling. And we had to set up sampling stations, which is where Nick USA and Well Health came in specifically to do sampling. And now they send it to our Kansas labs it's good for business, and it's also good for the turnaround time that you mentioned. It was not only important for healthcare reasons to identify cases, but it's really an economic stimulus to get businesses fully functional and back at work. So we've taken that approach, which you just have described.
Well, perhaps you could explain to us a little further about what sampling is, Secretary.
That's when you stick a swab into a person's nose way toward the back and you get samples, or you gather the sputum, the saliva, or you stick a swab in the person's nose and you run it on a rapid test. The sampling, just now we're starting to get more available things where a person can do that in their own home, send it in the US mail or FedEx to one of the labs like we talked about, CRL or MAUD. And they can run that. So we're just now starting to get that technology available. The next big step will be rather like a home pregnancy test where people can do this on their own. There's nothing approved right now by the FDA for home COVID-19 testing, but that will be a real breakthrough when it happens. But we'd like to do the sampling because one, if a person doesn't have the swab done right, it will not be an adequate specimen. And so the sampling was everything. We were starting in the summertime with our Kansas labs saying, can you help us? And but they're set up to run tests. They're not set up to do samplings. And that was the hardest part because we're doing, as you know, thousands and thousands of these every single day. So sampling is tough.
But it goes back to the issue is that what WSU is doing is they will train, let's say it's Boeing, for example, or not Boeing, it's Spirit now. So they train some people out at Spirit to provide the saliva test. WSU picks up those tests and they run it at their lab. And it's my understanding that we're paying somewhere around $40 on that. Maybe it's 50, I think it's around 40. But we're paying this other company around 150 for collection and testing. Is that correct? Or is it $200?
Well, I don't know. I don't know enough, ma'am, about the specifics in the contract. But as soon as Wichita State was able to turn that on, we went into a contractual relationship with them. I think that's a little bit under in terms of the dollar amount. I can get you the specifics of the contracted amount. It's there were testing sites in the state of Kansas that were charging $1,000 a test, and we've worked very diligently to be stewards to make sure that we weren't getting price gouged by anybody. Wichita State was one of them. MAUD and CRL and the other partners with us have come together very tightly in terms of their prices, and because we want to be able to test as long as we can.
Well, and I'm not going to, Mr. Chairman, I'm not going to take more of the time up here, but because I think we need to have that discussion, is that there is an inequity with what you pay for a testing from the WSU lab versus this WellHealth or WellCare, I'm sorry.
Well, we don't really have to do the testing anymore, though. They just do sampling.
Who does?
WellHealth doesn't do any testing. They just do sampling.
Okay, so where are they sending the testing? Where are they sending the sample? Where?
They send it to the other Kansas labs, MAUD, CRL.
Okay, but what we pay Wichita State versus what we're paying for the collection, because I don't think we're paying a collection fee to Wichita State.
We just last week got an itemized bill from them for the dollar amount they're billing us. And to be honest with you, ma'am, I don't know what the dollar amount is for sampling.
Okay, committee will move on to further questions. Do we have any more questions for the secretary before we move on? Okay, seeing none, Mr. Secretary, thank you. And is it Sarah Verdig next?
Yes.
Okay.
Yes, thank you, Mr. Chair.
Sarah, again, welcome back to the committee.
Thank you, Mr. Chairman. So Marisa has our roadmap for the presentation, for the rest of KDHE's presentation. I'm going to start going over some basics with KanCare and then move into some more specific areas. And then following me, Chris Swartz, our Director of Operations, will give an update on the eligibility and clearinghouse issues. I would also point out to the committee that the last bullet under my presentation, the KanCare Executive Summary, that's actually a separate document. So I won't be going over that, but we provided that to the committee as a separate document that you can reference. And if you have any questions about any of those, I would be happy to answer them as part of my presentation. Now, before I get into the slides that I'm going to be talking about, for the benefit of some of the new Bethel members, I wanted to share a couple of observations that I've noticed over the 8 months that I've served as the state Medicaid director. The first is one that I mentioned at the very first Bethel committee I presented at in this capacity, which is that Medicaid is an exceedingly complex program. It's basically a contract between the state of Kansas and the federal government. And the feds really drive the program through a lot of the rules and CFRs and other provisions of federal law. So it's really quite complicated. And very often something that might sound like it's a very simple proposal or very simple change to the program actually isn't, because of all those federal rules we have to comply with. However, luckily, within KDHE and KDADS, we have people who are experts in this. So they know all those rules and how to maneuver among them to stay in compliance with those requirements and keep our Medicaid program strong. So I would suggest that if any of you ever have a question about Medicaid, please don't hesitate to ask me or ask KDADS. If I don't know the answer, someone here does, and we can get that information to you as soon as possible. The second observation, and you heard some about this with the conferees this morning, is that a lot of provider groups feel that their reimbursement rates are inadequate for the services that they provide to Medicaid beneficiaries. And during my time in this position, it's something that I would like to start to try and address. We want to look at the program as a whole. It's difficult to kind of address rate increases piecemeal without looking at the program as a whole. So I wanted the committee to know that I've asked our staff to start looking at where some of those rates have been stagnant for a long time. For instance, I'm aware of some provider rate reimbursements that have not budged since the early 90s. And obviously, cost of everything has gone up since then. So it's something that I think we should consider as a state, but on a global level, throughout the entire Medicaid program. And for reasons that I'll go into shortly, it's important that we start thinking about prioritizing where those increases might be, and we need to be strategic about it. So with that, Marisa, can we move on to the next slide, slide 5? So just again, for the benefit of the new members of Bethel, in case you don't have a whole lot of exposure to Medicaid or KanCare in particular, I wanted to spend a couple minutes and just give you some basic background and hopefully help you understand some of the acronyms and terms that you're going to be hearing. You already did hear this morning and will hear throughout your tenure on the committee. And I don't normally put this many words on slides, but I was hoping that these could be a convenient reference for the committee members in case you get home over the weekend and think, well, what did she say on that particular area? So there's a lot of words here, forgive me, but it's by design. So as I mentioned, Medicaid is a state and federal partnership, and the Centers for Medicare and Medicaid Services, CMS, their job is to approve our state plan, which basically informs the feds on how Kansas is going to choose to administer our Medicaid program. And in exchange for that, the federal government usually pays for about 59% of our Medicaid medical costs. Currently, due to some coronavirus-related federal legislation, we're receiving 6.2% additional federal funding until the public health emergency ends. And I'll go into that a little bit later in my presentation. The original KanCare program went live January 1, 2013. Long-term services and supports, or LTSS, for the IDD population, that was added 1 year later in early 2014. I think it was February of 2014. The KanCare program is authorized under Section 1115 of the Social Security Act. So you'll hear us talking about our 1115 waiver. This is what we're referring to. Section 1115 waivers are demonstration waivers, and it's basically an arrangement that allows the federal government to waive certain requirements that would normally apply to Medicaid to allow the state to demonstrate that we can do something more innovative. Let us try something else and see if it works. That's what KanCare is authorized under. The first KanCare 1115 waiver was for a 5-year period running from January 2013 through the end of calendar year 2017. Kansas asked for and was approved for a 1-year extension. And then in January of 2019, KanCare 2.0 went live. This is another 5-year 1115 waiver, and it runs through the end of December in 2023. And currently, our 3 KanCare MCOs, United Healthcare, Sunflower Health Plan, and Aetna Better Health of Kansas, they cover about 95% of our Medicaid beneficiaries. So it's a strong managed care program. And you also hear us mention the STCs, the special terms and conditions. These are the rules that we have to comply with in order to maintain in compliance with our 1115 waiver. Marissa, can we move on? Thank you. A little bit more background. It can be confusing sometimes because Medicaid is broken over 2 different state agencies. And so here I talk about the differences between them. KDHE is a single state agency for Medicaid. CMS requires that each state have a single state agency that's kind of their single point of contact for all things Medicaid. In Kansas, that's KDHE, Division of Healthcare Finance. And we're responsible for the overall compliance of our 1115 waiver, in addition to Medicaid eligibility, finance, and just overall compliance. KDADS administers our 7 home and community-based services, or HCBS waivers, and those support individuals who qualify for an institutional level of care, but they choose to live in the community at home. And the HCBS waivers provide supports to enable them to do that safely. And so you'll see, if you're on budget committees, you'll see that Medicaid caseloads budget is broken across the 2 agencies. And KDHE and KDADS, we're in constant communication. We have to be for the Medicaid program to be successful. So we have a very good working relationship. A little bit on Medicaid eligibility. I could do an entire presentation just on eligibility, but I've included a hyperlink in our slides to quickly link you to our current Medicaid financial eligibility standards. In essence, to qualify for Medicaid, you have to meet certain financial eligibility standards. If you are applying for an HCBS waiver, you also have to meet what is known as a functional eligibility standard. In other words, you have to be evaluated by an independent entity and determined to meet and need an institutional level of care. And Senator Gossage, earlier this morning, you had a question about wait lists, and I made a note here. I wanted to make sure the committee knows that those who are on a wait list for HCBS services, they're still getting base Medicaid services. So they can go to the doctor's office for a checkup, and Medicaid will cover that. What they're waiting for and what they don't have yet are the specific services that are available on that waiver. So someone who's on the IDD wait list, for example, if they've been approved for Medicaid, they are able to go to the doctor, get prescriptions filled, that kind of thing. They just aren't receiving waiver services yet. So I wanted to make sure everyone was clear on that. And then our applications go through the KanCare Clearinghouse. Chris Swartz will give an update on this later. But as Dr. Norman referred to, we have a new eligibility contractor for family medical applications, and that's Conduent. And Chris will provide more information on that in a moment. Marissa, can we move on? Thank you. And I wanted to talk a little bit about what's known as budget neutrality. And committee, forgive me, this is some very dry material. However, it's very, very important that we all understand it because it is a defining characteristic of a Section 1115 waiver. An 1115 waiver requires Kansas to demonstrate that our program is budget neutral, which means that we cannot cost more federal dollars than we would if we didn't have our 1115 waiver in effect. And we're subject to a limit on the amount of federal money we can draw down throughout our entire 5-year waiver period as part of our budget neutrality cap. That's what we refer to it. And the second major bullet in the middle of the paper talk about how when we began our most recent waiver period in January 2019, on paper, it looked like we had about a $1 billion budget neutrality cushion. and that we were projected to come in through the end of the waiver period about 570 million below our budget neutrality cap, which basically means that we had a lot of flexibility financially to invest in the program, make changes to the program, increase provider rates. However, towards the bottom of the page, I highlight two issues that immediately cut into that budget neutrality cushion right when our waiver started. And these have to do with the way CMS calculates budget neutrality. There was a 4% hospital rate increase that was not included in our budget neutrality cap. That has the effect of eating into our budget neutrality cushion at the rate of $22 million a year and $110 million over our 5-year waiver period. There were also some other policy changes that were made in 2016 to 2017, but took effect in 2018. And due to a timing issue with how CMS considers our data, none of those policy changes were included in our budget neutrality cap. And those had the effect of eating away an additional $30 million from our budget neutrality cushion. So on paper, we started off pretty good from a budget neutrality perspective, but due to the way CMS calculates our budget neutrality cushion, we didn't actually have as much as we thought we would. I would also add that in the summer of 2000, I'll go into this in more detail later, we discovered an error that CMS had made when they calculated our budget neutrality cap that had the effect of shortchanging us by about $395 million. So these are big numbers and they're very important to the state. So it's something we monitor closely. And Marisa, can we move on?
Oh.
Thank you. So just to give you kind of a status update on where we are with our 1115 waiver budget neutrality, it's important to remember that our budget neutrality cap remains the same across all 5 years of our waiver. So it's going to remain stagnant until December 31st, 2023, the end of our waiver period. It doesn't matter if there are changes in state law that affect the way we spend Medicaid money. It doesn't matter if we make changes to our Medicaid state plan, that cap remains the same. We are able to ask CMS to amend our budget neutrality cap. However, I will explain on the next slide. It is a rare occasion when they actually approve that. And I have an example of that on the following slide. So what this means for Kansas is that we are at risk, meaning we will not receive federal matching funds for costs that are above our budget neutrality cap. And if it looks like we're going to go over our budget neutrality cap, CMS can put us on a corrective action plan that would involve bringing our costs within our budget neutrality cap or possibly making some adjustments to the way it's calculated. And our special terms and conditions specify that if we exceed our budget neutrality cap, the excess federal funds must be returned to CMS. So it is imperative that we keep an eye on this and make sure that that doesn't happen. And some takeaways for the committee that I want to make sure everyone is fully aware of is that every time we make a change to KanCare provider rates, it's going to affect our 1115 waiver budget neutrality. It doesn't matter if SGF is spent or not. Every additional change to KanCare provider rates has an impact on budget neutrality. So the key takeaway here is that whenever we're talking about changes to the Medicaid program, in addition to the question, what's this going to cost us? I would also encourage legislators to also ask the question, what will this do to our budget neutrality? Because there are some changes we could make to the Medicaid program that will not affect budget neutrality, but I would encourage legislators to be sure to ask KDHE so we can tell you and advise you on that. So over the next 3 years, we're going to continue to have this conversation with lawmakers on how best to prioritize additional investment in the KanCare program to stay within our budget neutrality cap. And I look forward to continuing that conversation. Mr. Chairman, if you like, I can pause here if there are any questions on that overview. Otherwise, I can move into our next slides.
Yes, I think we do have a couple of questions. Representative Carpenter.
So, Director Fertig, thank you for being here. So on that neutrality cap, we were talking about $390 million. So a couple of things come to issue. The frail and elderly waiver Medicaid to nursing homes. Is that affected?
Yes, all of our HCBS waivers are within the umbrella of our 1115 waiver. So our spending on all the HCBS waiver programs could have a budget neutrality impact depending on the policy change that's being contemplated, yes.
And on top of that, the TA waiver or the T1000 is what I mean to say, that also?
Yes, that would, Representative Carpenter, increasing that provider rate for specialized medical care, that would have an impact on budget neutrality.
And then I heard you talking earlier about discussing increases in provider rates.
Mm-hmm.
So that would also affect that, correct?
It absolutely would.
Until we get this taken care of, then that's just discussion.
Well, I mean, we are not exceeding our budget neutrality cap right now, Representative Carpenter. So I think we have room to talk about that, but I think what we all need to be mindful of is that there's not an endless amount of spending we can do to bolster provider rates because we are constrained by the budget neutrality cap. So I just want to make sure that we're all aware that we should be prioritizing what's most important and just be mindful that, you know, as even if we snapped our fingers and suddenly invested $300 million in Medicaid, that might not be something the feds would allow because of our budget neutrality cap.
So then remind me how much leeway we have.
Well, our actuaries are monitoring it, and I wish I could give you a solid number on it, but unfortunately, that's not really the way CMS set up our budget neutrality cap. It's based on how much money we spend per person per month. So if we have more folks joining Medicaid, if our enrollment increases, that doesn't really affect our budget neutrality. What affects it is how much we're spending on each person per month. And our actuaries have been monitoring this very closely at my request. And they've given us 3 different projections. If we keep our costs at about the same year-over-year increase that we have now, we'll come in comfortably underneath our budget neutrality cap. If our year-over-year costs ends up on the high side, it'll be very narrow. We will still come under our budget neutrality cap, but we will really have to monitor and limit additional expenses over the next couple of years. So it kind of depends on what the actual expenses are going to look like. So we don't have a specific number. And I would add to that, Representative Carpenter, I want to make sure everyone's clear. Medicaid expansion would not affect our 1115 waiver budget neutrality currently. Our actuaries have informed me that the way that works is the Medicaid expansion population would be under its own budget neutrality cap. So adding that would not blow a hole in our budget neutrality. It wouldn't affect it at all, actually. It would be subject to its own cap. I hope that helped, Representative Carpenter.
One more follow-up question. Okay, so we have this increased FMAP, 6.2%. The latest numbers that I pulled, we have almost 50,000 more people on Medicaid than we had last year at the same time. Does that affect our budget neutrality?
I'm so glad you asked that question because I asked the same questions of CMS. So the increased FMAP does not affect budget neutrality. It just changes the allocation of the money that we're spending per member per month. So we're just spending less SGF, same amount of federal funding, but
Sarah, I think you froze. Might have just got disconnected.
did you lose me?
We did briefly, but
Sorry
you're back
about
now.
that.
Thank you.
I'm not. Okay. I'm not sure where I left off, but the short answer is that the change in the FMAP percentage does not affect budget neutrality. And the way our budget neutrality cap is written, It doesn't matter if we add more people to the Medicaid rolls. All that matters is if the amount we're spending per Medicaid member per month goes above the cap. I hope that makes sense. I know this is complex.
It kind of does, but one of my big concerns is, and why I think the feds have given us a 6.2 is, arguably, depending on the eligibility, it's 1 year. So whenever the emergency order ends, we're going to owe the bill on that 50,000 people for arguably, until we can audit the system, 1 more year, or 11 months, or however long that eligibility. What will that do?
I think Chris Swartz might get into this a little bit in her presentation, but we do have a plan. I think what you're referring to, Representative Carpenter, is the fact that we are currently not discontinuing folks from Medicaid eligibility due to that is a condition of us receiving the 6.2% increased federal match. So we do have a lot more folks on the Medicaid rolls now than we normally would as a condition of receiving that increased federal match. We do have a plan in place to roll folks off of Medicaid once we're able to start doing redeterminations and terminating coverage for those who are no longer eligible. And I think Chris can correct me if I'm wrong when we get to her, but I believe that our plan would allow us to do that over a 6-month period. So once we get the green light to start doing redeterminations, we can do that. But you are right, Representative Carpenter. Our FMAP, our federal matching rate, will go back down to about 59% at the end of the quarter in which the public health emergency ends. And the Biden administration has signaled that they intend to renew the public health emergency every quarter throughout the rest of calendar year 2021.
Thank you.
Sarah, I've got a question for you, or one would be a clarification and one would be kind of a question. But for the new members on the budget neutrality, when you say the cap, that's over the period of 5 years, not annually, correct?
That's correct. The way our budget neutrality workbook that we report to CMS works, we sort of have an annual, but really they look at it over the course of 5 years. So we do have kind of a somewhat squishy annual budget neutrality cap, but CMS really cares about whether we're going to come in the limit over the course of the 5-year period.
Thank you. And then for my question, at the beginning of KanCare 2.0, the budget neutrality was roughly $1 billion. Who figured that amount?
CMS. That was CMS.
So then later, at what point did they refigure it and said, no, we only had 568 million?
So CMS calculated our budget neutrality cap, and based on their calculations and their projections of how much money Kansas was going to spend over the 5 years of the waiver, they projected that by the end of calendar year 2023, we would come in about 568 million under our budget neutrality cap. So those were both CMS calculated numbers.
I apologize. I'm trying to figure out the time frame difference from the 1 billion into the 568.
The 1 billion is what on paper Kansas started with as of January 1, 2020 or 2019. That was supposed to last us over the 5-year period. And the $268 million figure, that's what CMS calculated we would end up with. That's how much under our budget neutrality cap we would come in at the end of this December 2023. So they projected that we would spend the remaining amount down from our budget neutrality cushion over those 5 years, kind of gradually.
Okay, Sarah, I apologize. What I'm asking is, CMS figured 1 billion at the beginning of the 5-year period. When did they come back with the 568 million?
Actually at the same time. So what CMS provided to us is kind of their own calculation spreadsheet that shows where they project our expenses to be year over year. And so at the same time that we received the calculation saying that we would have about a $1 billion budget neutrality cushion. We also received the $568 million figure, which is where CMS projected we would be at the end of our waiver. So those are both numbers that we received at the same time.
So when did we find out the error in the CMS calculation that added the 395 theoretically back? They haven't proved it yet, but acknowledge that that was an error.
We found out about that last summer, and actually on the next slide that I'm going to talk about, go into that a little bit more detail, but with assistance from the Kansas Hospital Association and some outside experts, we reviewed CMS's budget neutrality calculation, and we realized that they left out a portion of our historical cost experience, that roughly $395 million number. And so once we realized that, we submitted a proposal to CMS to correct that technical error. And we submitted that proposal in September and have not heard from them as to whether or not they're going to approve it. I have had some encouraging conversations with CMS though, and the career staff that I spoke with indicated that they think it would be approved. But unfortunately, due to the upheaval that a presidential transition causes at the federal level, they need to wait for their leadership to be installed before they can officially approve it.
Because the reason why that kind of came to my attention, 395 plus 568 is close to $1 billion. So I just, maybe explain maybe explain to us how the CMS will give you $1 billion and then 568 in the same document, and it's contradictory to what the results should be. How did that come about? And I guess a better question would be, why did we not double check it earlier? Or did we, or we just didn't have the resources to do it? Or it's just confusing to me of how that happened.
Yeah, thank you, Mr. Chairman. I appreciate the opportunity to clarify a little bit. So the 568 million number. So what CMS did is they figured out what they thought they would spend on Kansas Medicaid in the absence of this 1115 waiver. So that's when they calculated that is the $1 billion number, because budget neutrality requires us not to cost any additional federal money than we would cost in the absence of this waiver. So that's what that number is. It's known as the without waiver amount. CMS calculated that Kansas Medicaid would cost, about $1 billion more without this waiver. So that's what's known as our budget neutrality cushion. Then they applied some projections, assumed that there would be some policy changes made by the state over the course of the 5-year waiver period. And they figured that we would be spending, $400 million and change in policy changes, and that at the end of the 5-year period, we would still cost $568 million less than we would without our 1115 waiver. So I hope that makes a little bit more sense. That's what those numbers mean. And in terms of, these errors, I was not here during 2018 when the negotiations with CMS to renew our waiver were going on, but I have had many conversations with those who were, and I can tell you that the Kansas team fought very, very hard to get a fair budget neutrality cap for the state. However, because the federal government are the primary payers, our bargaining position is a little bit stunted. There's a limit to how much bargaining power we have. And ultimately, in order to get the federal government to approve renewing our 1115 waiver, the state kind of had to agree with their final and best offer, and that's what we're working with now.
Thank you. Committee members, do we have any further questions? Representative Concanon.
Just a quick one. So that 5 years is up on December 1st. Where did I see that? Of 23.
Mm-hmm.
So when do we start working on the next 5 years?
That is a fantastic question, Representative Kincaid. Thank you so much. Honestly, we're starting to think about it now. I mean, this is a huge ship that we're steering. And so if we're going to consider other sources of authority that we could operate the KanCare program under, we need to start doing that now. And, you know, one thing that we're exploring is if there are other ways that we could essentially keep the KanCare program the same as it is now, but not have to deal with the budget neutrality cap. So that's a very, very timely question, Representative. And I want you to know that we're having those discussions already, trying to figure out where we go from here.
Great, thanks. That's just what I wanted to hear. Thank you.
Representative Ballard.
Thank you, Sarah. Now, if we do that, you're thinking about it now, but once we set whatever that amount is, does CMS monitor it as we go along to see that we are in keeping with that 5-year plan? Or do we have to monitor that to make sure we don't go over and that we stay about neutral is what they want us to do so that it doesn't get out of whack? So who monitors that?
Thank you, Representative Ballard. And the answer is both. We monitor it internally. Recently, I've looped in our actuaries to help us with that effort. Our finance team also monitors it, but we also regularly report to CMS what our actual expenses are. So they are monitoring what our actual per member per month costs are. So they have a good view of what our budget neutrality status is on a regular basis with our regular financial reporting. So they're looking at it, and so are we.
Okay, so at one point it's projected, but then you actually send the actual figures. Is there a time lag in there that creates a problem?
I don't really think so. I mean, Medicaid is such a large program that even if, you know, there's a 3-month lag in reporting actuals, that's not really enough to make a huge change in our per member per month expenses. So no, I don't think so, Representative Ballard.
Well, thank you. That is helpful. I think maybe I'm getting a grip on on 1115 because it's always been out there. I wasn't sure. So you've done a good job explaining it. Thank you so much.
Thank you.
Representative Carpenter.
Thank you, Mr. Chair, and I apologize for coming back a second time. So HCAP, that's under the budget neutrality. And so we do have an application in for raising HCAP to 3%. And you're gone. Maybe you can hear.
I can hear. I can hear you.
We do have an application in to raise for HCAP to raise it to 3%, inpatient and outpatient. So that's probably the most amount that I can think that would be dangerous to our budget neutrality. Is that accurate?
Yes, and thank you, Representative Carpenter, for asking that. So we did, as you may know, and I'll go into this a little bit further in the presentation, or I could just go into it now. In 2019, the legislature passed some changes to the HCAP program. That's the Healthcare Access Improvement Program. It is a program where we impose a provider assessment on hospital providers, and then we use that assessment revenue to draw down federal matching funds. And then that pool of money is used to increase rates for hospitals and physicians. So it's a way to help bolster rates without using any SGF. And there was some legislation in 2019 and 2020 that would improve the HCAP program. Right now, the tax is on 1.83% of inpatient revenues. The legislative changes would increase that to up to 3% of inpatient and outpatient revenues. And the net effect would be to draw down a significant amount of federal dollars to help bolster this program and improve provider rates for hospitals and physicians. In the middle of the slide, you can see in July of 2019, my predecessor, Adam Proffitt, who's now our state budget director, we submitted a technical amendment to CMS to effectuate those changes to the HCAP program. As Representative Carpenter alluded to, our existing budget neutrality cap could not support that level of investment into hospitals and physicians. So we needed to request a technical amendment to our 1115 waiver to adjust our budget neutrality cap to accommodate those changes. And I can tell you that the state pushed really hard and did a very good job trying to convince CMS to approve it. However, we learned in May of 2020 that they were not going to approve that technical amendment. However, we never received a formal notification that they'd rejected our proposal. And so technically it's still pending with CMS. I had an excellent phone call with CMS at the end of January with some career staff in their 1115 division who know the Kansas program. They know 1115's inside out, and kind of reiterated Kansas's position that we really need this to be approved because this is such an important enhancement and investment in hospitals and physicians. And what I was told by the career staff is that they still didn't think that this was something that they could approve, but they did acknowledge that the incoming administration might see things differently. So it was kind of a mixed bag in my conversation with them on that HCAP amendment. So career staff is doubtful. However, they did acknowledge that the Biden administration might see things differently. So we're continuing to monitor that. And Mr. Chairman, if there's more questions on budget neutrality or what I've talked about so far, I'm happy to entertain them. Otherwise, Representative Carpenter has given a very good segue to my next slide. I can move forward with that if you'd like to.
Sarah, I think that would be a great segue. So
okay.
Go ahead and continue. Thank you.
Okay, sure. So the HCAP, and for new Bethel committee members, you're going to hear us using this acronym. So I spelled it out for you for your reference. If you are statute geeks like I am, the statutory reference is KSA 656207 at SEEK, if you want to see the actual language. So kind of talked about how, we had requested a technical amendment to our 1115 waiver to accommodate these HCAP changes that wasn't approved. As we were kind of regrouping and figuring out what to do next, that's when we discovered that CMS had made an error in calculating our budget neutrality cap. So the second to last paragraph on this slide kind of goes over what I just talked about, which is how we think that CMS understated our budget neutrality cap by $395 million. So we have two pending proposals in front of CMS currently. One of them is a technical amendment to our 1115 waiver to make the changes to the HCAP program that the legislature prescribed. And then the second is a technical correction proposal to fix an error in our budget neutrality calculation. Now on the second one, the technical correction proposal, in the same conversation I had with CMS in January, the career staff, they expressed quite a bit of optimism that they thought that that would be approved. They did caution though, again, that the presidential transition is, causing some delays and asked us to be patient. I reached out to one of our CMS partners yesterday for an update. I haven't heard back from them yet, but I will keep the committee apprised on how that works. So, and in the meantime, we're just continuing to monitor the HCAP program. Marisa, can you move on? Thank you. Update on regulations. As you may recall, when we were talking about issues log, I did ask for possibly considering the protected income limit item to be closed. And this would be why, KDHE has done everything we can on the protected income limit at this point without additional legislative intervention. So we amended our regulation, officially writing it into law that for the purposes of the HCBS and PACE programs, the protected income limit is $1,177. So that became effective on January 1, 2021. And Marisa, can you move on? Thank you. Additional updates. KanCare Kansas is a program that we launched in April of 2020. So right in the middle of a pandemic, not great timing, I will admit that. But it is a program that provides for coordination of behavioral health and medical services for individuals who meet certain eligibility criteria. And so far, the program is going pretty strong. We have 33 providers enrolled as KanCare partners. And as of February 1, we had 1,027 members enrolled in the program. 586 of them were enrolled in the asthma population, and 441 of them were enrolled in the serious mental illness population. And so this program is going well. And if anybody has any questions on that, I'd be happy to answer them at the correct time. And in the meantime, Marisa, thank you. This is another item that has appeared in our issues log that I suggested perhaps we could close. We have a name for this now. In our 1115 waiver, the state said that we would implement a voluntary pilot program for up to 500 eligible KanCare members. It's a supported employment pilot. We have a name for it now, the Support and Training to Employ People Successfully, or STEPS pilot program. There have been some delays in getting this program off the ground. Originally, it was scheduled to get off the ground in July of 2019. Due to some staff retirements and recruiting and then COVID, that has been delayed. However, we're making a lot of progress. And since December, we've hired 2 additional benefits specialists and a program manager who are going to support the pilot. We're in the middle of drafting a manual, and MCOs are working to identify financial management services providers for the pilot. And we have an advisory board that meets regularly, and they have a breakout group to work on outreach strategies. So I'm pleased to report that our target go live date remains July 2021. Some recent highlights on COVID-19 as it relates to KanCare. We've received a lot of questions about whether or not KanCare Medicaid covers COVID-19 testing and vaccines. The answer is yes. I provided hyperlinks on this slide to the bulletins that contain information about that. Earlier in my testimony, I mentioned that the public health emergency, the Biden administration has indicated they're going to renew it throughout calendar year 2021. That's important because under federal law, Kansas can draw down an additional 6.2% increased federal participation for Medicaid and 4.34% increased federal participation for CHIP through the end of the quarter in which the public health emergency ends. So currently, the Biden administration has signaled that increased federal match is going to be available to us throughout the entire calendar year, which is great news for Kansas. And then lastly, we do have that Kansas vaccine website up and running. There we go. The next couple of slides are really just background information. We've been providing these same slides basically since COVID started, just to give you an idea of what we've done to adjust KanCare to the challenges of the pandemic. And if you have questions about any of these items, I can go into them. Otherwise, Marisa, we could skip over to slide 15. That shows additional authorities that we've exercised. And then on to slide number 16, kind of a summary of some of the changes to KanCare we've made in light of the pandemic. 2 that I will highlight are the first bullet, that we are delaying eligibility reviews. This is in order to draw down the additional federal matching funds. In essence, we are not terminating anybody from Medicaid unless they cease to be a resident of the state or they voluntarily withdraw from the program. So that's been a big change. It's resulted in an increase in the number of folks on the Medicaid rolls. As of last month, it's about 460,000 total. That's about 60,000 more than we normally have. And then the third bullet down, this is also important because we received questions about this. We've removed all cost sharing for COVID-19 testing, treatment, and vaccine for KanCare members. Moving on, the next 3 slides are just kind of screenshots of our Kansas Medical Assistant Program, our KMAP website, and some of the bulletins and policies that we've implemented in light of the pandemic. And Marisa, if you could switch to the next one. And then the next one as well. And if anyone has questions about that, I'm happy to answer. And in the interest of time, Mr. Chairman, I might just highlight a couple things for the next several slides because they have pretty graphics on them that I think speak for themselves on the analytics and performance metrics. Marisa, can you switch to slide 21? One thing I would point out is that our enrollment by MCO has remained pretty much the same over the last 2 years. United and Sunflower have about 36% each. Aetna has about 27, so that's remaining fairly consistent. And Marisa, could you move to slide 22? This slide shows information about the volume of claims that we see through the Medicaid program. And you can see that the volume is very, very high. Consistently, pharmacy is at the top. The most number of claims are going to come from pharmacy. So that's been pretty consistent. Let's see, could you skip to slide 24, Marisa? Another thing I want to highlight here, clean claims processed within 30 days. In calendar year 2019, Aetna struggled with this a little bit. However, they reported to us a couple days ago that they are now at 99.9% clean claims processing. So just a hair short of 100%, but they've been making steady progress on that. So we're very happy to report that. And, you know, in the interest of time, Mr. Chairman, I would probably switch to slide number 31, Marisa. This is something we report at every Bethel. This is the MCO profit and loss per NAIC filings, just so you have an idea of where the MCOs are coming in financially. And this is the same information that we presented in December. We will get updated information in March. So I anticipate at the next Bethel meeting, we'll have some additional information here. And with that, Mr. Chairman, I'm happy to stand for any questions, or I can hand off the slide deck to Chris Swartz for an eligibility update.
Committee, do we have any questions on any of the slides? Not seeing any. Sarah?
Mr. Chairman?
Oops, we have one.
I'm sorry, I didn't get my, I didn't text you fast enough. It's good
Representative
to see you.
Landwehr, go ahead.
That's, okay, I'm trying to get back to my page there. Okay, on page 16, I think it's the first question. Oh, no. Let's go back to page 12. Sarah, on this STEPS program, was this something that was authorized through the legislature? Explain how this came about, please.
Representative Landwehr, this is the 1115 behavioral health employment pilot. We've just given it a name. So this is the same pilot program that we've been talking about for the last several Bethels. We just have a name for it now. And okay. This was included in our 1115 waiver.
All right. And then on okay, on page 13, as you talked about the enhanced Medicaid dollars, the current year, that was worth about 300 million in that ballpark for us, I believe.
Ballpark.
But that money's not and I want people to understand this very clearly. That money's not necessarily going back into health programs. This money is being used to supplant SGF in other areas of the budget. Is that correct?
That is absolutely correct.
Okay. And then on page 16, okay, as you were on your bullet 3, how is that being paid for then?
Through Medicaid. We just don't have any cost sharing for KanCare members.
All right, good. And then on the reimbursement to a family member, how does the family member then qualify to receive this reimbursement? They just can't say, I'm going to do services, correct?
I would defer to KDADS on the mechanics of that. That's actually KDADS policy, Representative.
All right. And then down on the fourth from the bottom bullet, allow for out-of-state non-KanCare providers to provide services in Kansas.
Mhm.
Can you elaborate just a little bit on that, what that means to us?
Sure. This is sort of a temporary accommodation for during COVID. We want to make sure we have sufficient providers. And so I think one of the links, possibly on a KMAC website, addresses this, but this was a decision that was made last spring to make sure we had sufficient providers to deal with testing, to deal with treatment, anything like that.
Okay, and then was there a fiscal associated to the pass-R scores?
That's an excellent question. I don't have.
I think we would find out that there's a fiscal. I think that that would be a good number for us to take a look at.
Sure, we can get that back to you.
All right, thank you very much, Sarah.
Thank you. And we have a,
Mr. Chair,
yes.
this is Representative Susan Ruiz. I have one question for Sarah.
Go ahead, Representative Ruiz.
Thank you. It's a very simple one. Sarah, can you tell me how many additional people have come on to the to Medicaid since the COVID or due to COVID?
Ballpark around, well, additional coming on. We haven't really seen much of a change in new people coming on. Interestingly, the number of applications we've received took a dive after COVID. And we think part of that was because of the change in policy driven by the federal government that we're not terminating people from coverage on a routine basis as we were before. So our overall numbers are up, but that's largely driven by the fact that we're not doing redeterminations currently and terminating people from coverage as a condition of receiving that enhanced federal financial participation.
And you had mentioned there's about 460,000?
Mm-hmm. Yeah,
Right?
ballpark, yes, on Medicaid.
Ballpark. Okay, awesome. Thank you.
Sarah, I don't see any further questions, so if you want to go ahead and do the handoff, I think we're ready.
Absolutely. Chris, are you on?
Yes, I am.
There she is.
Thank you, Mr. Chair and members of the committee for the opportunity to share some information with you today. My name is Chris Swartz, and I'm the Director of Medicaid Operations at KDH&E. I'm going to provide updates to the status of the Medicaid eligibility applications, the federally facilitated marketplace open enrollment, the transition of the Medicaid application processing for elderly, disabled, and long-term care to the state, and the status of the clearinghouse RFP and now also contract. And I can also answer and follow up on any of the questions that you have on the impact of continuation of the reviews and our plan to resume processing of those yearly renewal once the public health emergency is over. So first, thank you, Melissa. I will go into the status of the Medicaid applications. As you can see, very good status of where we're at on number of applications that are over 45 days, which would be the application at risk of not being in compliance with federal guidelines of processing within 45 days. The total number of applications that we have in-house are 3,148 as of the date of this report. And of those 3,148, a total of 167 are over 45 days. That's about 5% of the total number in-house. 81 of these 167 are in what we call an active status, which is we've received all of the information that we need in order to actually move on with processing and make a final determination on that application. 86 of the applications are still in a pending status, which means that we cannot continue processing until we are getting more information from either the beneficiary, a family member, the provider, or a financial institution, depending on the nature of the case. So very good numbers. This slide is there to basically provide the committee an update on whether or not we're getting back into a backlog situation on processing of applications, and that is not the case. So we can move to the next one. My next update is going to be on the federally facilitated market open enrollment. Yearly, the market opens enrollment from November 1st to the middle of December. And for this year, it started November 1st of 2020 last year and ended in December of 2015. In that short period of time, we received 16,861 applications from the marketplace. And you can see the breakdown there. The majority of them fall into the family medical grouping, 10,561. The remainings are in the elderly, disabled, and the long-term care areas that are significantly lower than the family medical grouping. Next slide, please. Then on the 12th of February, the CMS, the Center for Medicare and Medicaid, announced that they were going to open a special enrollment period from February 15th, so this week, Monday, and that the special enrollment period will continue through May the 15th. During this period of time, since this week, we've received about 400 applications from the market already, and we are basically managing that second open enrollment. It was not expected, but we're ready to manage it and make sure that it's going as smoothly as the first open enrollment period of last year. Then I'm going to talk a little bit, and I left those slides here. There is a lot of old information there, but I thought in the interest of on the committee, I would give a little bit of background of what had happened in the area of eligibility. We had eligibility determination is contracted out to an outside contractor, and at the time before we did the transition, that contractor was Maximus. Because of performance issues and other issues, we decided to take a number of steps to resolve the issues that we had. And one of the steps was to bring back in-house and for processing at a state level of the group of applications that were the more complex in processing and determination of eligibility. We started the transition of the responsibilities from the existing contract for Maximus in 2019. And by July of 2019, we had transitioned all responsibility related to training and quality monitoring and improvement to the state. Then between July of 2019 and January 1st of 2020, we then transitioned the responsibility of actually doing the eligibility determinations for the elderly, the disabled, and long-term care applications. And that was successfully completed on January 1st of 2020. That point in time, it means that the staff was responsible for the eligibility determination, also responsible for responding to questions by phone related to that group, whether it was HCBS, elderly disabled, and nursing facility applications. Right after the switch to the state staff for processing, we established regular meetings with the Nursing Facility Association and stakeholders to kind of take the pulse on, how was that transition going and were we having any issues or problems. And we have continued this communication on a bi-monthly basis now. These were more frequent than they were every 2 weeks right after the switch of the work from the contractor to the state. Then the table there below is just for information purposes only, that tells you, which pieces of the different part of the applications were actually converted between September and 2019 and January of 2020. This is just for information purposes. So the spend down program, for example, was transferred during November. The batch long-term program was in December, and so forth, and just kind of information purposes for the committee. The committee also asked us, because of the allocation of staff that that we had asked for, to actually process the work and ensure that there wouldn't be, additional backlog and accumulated and so forth. The committee asked us to provide some staffing information on a regular basis on where we were at from the staffing of the clearinghouse on the state side, the KDHE side. So we filled the majority of the position as part of the transition, but we continue to recruit, and it will be an ongoing process and an ongoing endeavor. And we're continuing to hire staff. Our training classes are very successful. We have managed to put a lot of the training, not only in active and visual training, but also online, where people, if they want to go back and look at very specific pieces of the training, they can do that online on their own time and at their convenience. So the table there gives you kind of an idea of where we're at in staffing in the different areas. And so bottom line, out of the 313 staff that we have allocated and scheduled for processing, we have about 60 vacancies, which is about 20% below the staffing level that we should be at. But we have put things in place and done things in a little bit of a different way, and being able to actually continue processing without accumulation of backlogs. Now I would like to give you an update on the clearinghouse contract. So Maximus, after the transition of the work to the state staff in January of 2020, Maximus continued processing the family medical application, which applications were a much simpler application. There's no asset verification. There's no trust to take into account. None of the application that the elderly and disabled are part of this program here. So for the end of their contract year of December of 2020, they continued processing the family medical applications in coordination with the state staff. Simultaneously, the KDHE issued a request for proposal to enter into a new contract for clearinghouse services in middle of 2019, and the procurement process was completed. And in August of 2020, we awarded a new contract to a new contractor, Conduent. So the incumbent didn't win, the contract. A different entity owned the contract. Conduent then began processing of the family medical application at the start of the new contract period in January of 2021. We had a transition period for this, for the work from the current contractor to the new contractor, that took place over a 4-month period of time, September for December of 2020. And that transition went very well. And despite the very aggressive implementation timeline, the transition from Maximus to Conduent was very smooth. Contributing factors to that were, we were ready for that. We knew it was going to be delayed, so we put we did some gap analysis of what would be our at-risk areas, and we filled those gaps by putting a whole bunch of different things in place, like repurposing our staff, putting things where they should be, moving things around so that the bottom line of not accumulating another backlog, which was the goal, would not occur. Maximus was also very collaborative in the transition, and Conduent was very eager to actually make sure that the transition would go very well and they wouldn't start, on a bad foot for with this new contract. So there were no disruption in services that occurred. We did briefly experience, and are continuing to experience, some issues with the call center. The technical issues were resolved immediately. The training issues are being addressed as we're finding them, but basically it's a question of staff becoming familiar with a new phone system, how the transfer of the phone calls from the call center to eligibility work specific information occur, but they're getting less and less and less frequent, and we're getting all of those resolved. So bottom line, the transition had no impact on our ability to process applications. All of this combined with the fact that we were in the middle of a public health emergency, and some staff had to be quarantined, couldn't be working, and we had more than a 20% non-showing up at work beside the normal vacancy of 20% that we had. But we basically made it, and we're continuing to process within the statutory timeline, and the clearinghouse as well as the state are ready to take on the special enrollment period. That these numbers and these applications come on top of the 11 to 12,000 applications that we receive for processing on a regular monthly basis. I think that completes my presentation, and thank you for your attention, and I'm ready to answer any questions that you may have.
Thank you, Christina. And we do have a question, it looks like, from Representative KanCare.
Thank you, Mr. Chair. Can you remind me where the KDHE clearinghouse staff is located? Did it stay where they were before?
Thank you for this question. So my staff, we could not find a single location for them. So the state clearinghouse staff is located within 3 different facilities. Another building than the contractor's building at Forbes, a building that we're leasing from, I believe it's the Department of Commerce. There was the old workforce center, and we have a contingency of staff over there. And then we also have some staff in the basement of the Curtis building. So we're spread across, a little bit across the city.
Okay, and then is Conduit, are they located where Maximus was before?
They are not. Their facility is not ready yet, but they are on 6th Street, I believe, and it's the old Payless building that they took over. And so that would be another location where we have state staff, because the Family Medical Clearinghouse staff that is co-located with a contractor, because Medicaid eligibility can only be finalized by a state person. So that staff is co-located with the contractor at the new location, or will be. Their location is not finalized yet.
Okay, great. I don't know why I need to know that, but it just helps me to picture where they're at. And I just want to make a comment that just want to congratulate you on the transition, both with the clearinghouse for the long-term care into KDHE, and then also from Maximus to Conduit, and have it go so smoothly. And I appreciate not having my inbox filled with complaints as they were 2 years ago, and making room for unemployment complaints. So thanks, Christine.
Thank you very much, Representative KanCare, very appreciated. And my staff really needs to be really commended for that. They are actually doing the work.
Representative Carpenter.
Thank you, Mr. Chair. Yeah, as a frequent railer against Maximus for the last however many years, since 2015, I really appreciate this. And Chris, just on that subject, I'm very happy about it, but, just, are you happy with the transition and the job that Conduit's doing right now?
I am. We're still very closely monitoring everything, because they're new, so we're monitoring the quality of the work. We have basically almost our state staff really focused, and our quality staff really focused on making sure that yes, they're processing application, but is it done correctly? So there's a lot of focus on that. We're happy, and I'm really happy with their responses. And when we ask for something, their willingness to actually be responsive and find a solution to the issues that we're raising. The minute we raise the issues with the call center and maybe there was something with the system that wasn't right, we immediately addressed it and, didn't wait, didn't question it, and went and found a solution for it. So right now, maybe we're in the honeymoon period, but it's going very well at this point in time.
Very good. Thank you. I think that also. So very good. Thank you.
You're welcome.
Okay, I don't see any further questions for you. So, Christina, thank you very much for your testimony on that. Committee, I think next up we have Secretary Howard with KDADS. Secretary Howard, are you available?
I am. Thank you. Thank you. Can you hear me?
I can, and welcome to the committee.
Thank you. Yes, I thank you for the chance to be here in front of the KanCare committee today. I'm here with my Deputy Secretary, Janice DeBoer, and Deputy Secretary Scott Bruner, as well as two of my commissioners, Amy Penrod and Andy Brown. And we have a lot of information to share with you, as you can see from your agenda. And I thought I might just context the presentation for just a few moments before handing it over to them. I know it's late in the day on a Friday of a long week, but I do think it's important to perhaps build just a little bit on what Director Fertig said in talking about the role of Medicaid across the two agencies. So, as Sarah indicated, while KDHE is the state Medicaid agency, KDADS, we're an important partner with KDHE. And those of you who work on our budget know this, I think, very well. But, Medicaid funded programs comprise more than 90% of the KDADS budget. I mean, that's really how significant Medicaid is in the supports and services that are provided to vulnerable Kansans, seniors, persons with disabilities. And in addition to the 7 home and community-based services waivers that Sarah referenced, of course, we also manage the nursing facility program, as well as behavioral health services, those critical mental health and addiction supports. So we really, we walk alongside KDHE very closely. And as she indicated, it can be a very complex program. And for any of the initiatives that we bring forward, any policy changes, we have to work all of those things through those Medicaid processes, through Sarah's great team at KDHE. On the finance side, on the program side, on the policy side. And sometimes when things seem like they take a bit of time, I mean, it's because of those important processes to make sure that things are really in compliance with Medicaid, that they can be supported within the existing waiver and the like. So I'm that was probably more of a context for members who might be a little bit newer to the committee in terms of why KDADS is on this agenda to the extent that we are. As you hear from my team today, I think one of the things that I hope stands out is kind of the parallel track that we've really been on over the last year, almost a year. Someone was reminding me that it had been the middle of March when so many of our team members began to work remotely. We're almost coming upon a year, but really 2 parallel tracks. All of the work that we've been doing related to COVID, whether that's the disbursement of resources, PPE, communication devices, all those things that Deputy Secretary DeBoer talked about earlier to our providers, all of the various policy changes to support the continuation of services, walking alongside with KDHE in terms of the Medicaid pieces, but also in terms of some of the work being done on the public health side that Secretary Norman talked about, really walking alongside them on issues of testing and vaccines, particularly related to the long-term care population. And you'll hear a bit more about that in our testimony today as well. So that whole COVID track on one side, and yet we've still continued to advance forward, I think, key critical initiatives. And you'll hear about those. You'll hear about how we're continuing to focus on improving services for youth in our behavioral health program. You'll hear about the focal areas within our home and community-based services waivers and some pain points right now as we face some challenges in managing, for example, the brain injury waiver. But again, I'm just so very proud of the work that my team has done over the course of this year, kind of walking down those parallel paths, continuing to advance forward while at the same time adapting and supporting our partners and providers to adapting to a different world. You know, I could talk in more detail about any of the topics, but I think, Mr. Chairman, I'm happy to take any questions right now, or I'm happy to take any questions at the end after my team has, you know, gone into a little bit more depth on these topics.
Thank you, Madam Secretary. Committee, do we have any questions for the Secretary at this time? Not seeing any, we can proceed. Thank you.
Great. Okay, I'm going to hand this over to Deputy Secretary DeBoer to kick us off and talk about receiverships and nursing facilities.
Good morning again. Good afternoon again, members of the committee on this Friday. I am Janice DeBoer, Deputy Secretary at KDADS. I mentioned earlier during the issues log presentation on slide 4 that KDADS did take 22 adult care homes into receivership. But on a positive note, on a good front, we only have one facility remaining. One facility closed in 2018, one sold in early 2019, and then you all are familiar, I'm sure you recall, the Skyline facilities, which Kansas had 15 of those, and those sold in October of 2019. The remaining facilities have sold, and then just February of this year, we had a successful transition. So again, only one facility remains on the market. I think, again, it's important to note that Secretary Howard and I and Scott and several of us are very sensitive, and we're being very thoughtful as we hear concerns from nursing facilities across the state that they are concerned with the finances of nursing facilities across the nation, and Kansas is not unique to that because of COVID. So we're sensitive to that. We will be as responsive as we can be. We will keep you up to date as we hear more from the trade associations and from our nursing facilities directly. On the next slide, I just want to make sure that I do a better job in the upcoming months and years of talking about the nursing facility program. I was thinking back, and I believe it was 1997 that the nursing facility program, the Medicaid nursing facility program, transitioned over to KDOA at the time. And KDOA, now KDADS, has managed this nursing facility program for so long, I think sometimes folks even forget that it was ever managed elsewhere. But it is a large program for us. We do take care of the Medicaid enrollment, the change of ownerships, the rate setting methodology. And many of you may remember, some of you may not, Bill McDaniel from all the years ago, where he helped us with rate setting for years. Some of you probably remember Dave Halferty, who now works at Myers and Stauffer. So we still have a lot of responsibilities directly linked to Medicaid for the 10,000 plus residents who reside in nursing facilities on a daily basis. I will share with you, and you can see the rest of the list here, but I will share with you, we will be receiving annual cost reports from nursing facilities on February 28th. They are well, the February 28th is the close date that all nursing facilities must have their cost reports submitted. We believe this will be an unprecedented cost reporting period with COVID. We're holding our breath. We're not sure what to expect. We will keep the secretary apprised on a daily basis. Just as soon as we see some of the analysis, we expect costs to be higher than we've maybe ever seen before. And we expect caseload to possibly be the lowest we've seen in years. So we will be, we are waiting with bated breath, if you will, and ready to respond as needed to what the cost reporting costs look like this particular year. So I believe, Marissa, the next slide, I think I'm transitioning over to Amy Penrod, Commissioner Amy Penrod on slide 6, where she's good. Oh, nope, I had one more slide. Sorry about that. This just gives you a sense for new members in particular. For those of you who are the veteran members, this won't look foreign to you at all. We do have nursing facilities across the state, right at 328 nursing facilities on any given day. In Kansas, there are about 10,000 residents out of approximately 20,000 residents. So Kansas has maintained a 50% ratio mix of private pay to Medicaid for years. And we have about half of the residents who reside in Kansas nursing facilities are receiving Medicaid. So we just want to continue to share this with you, and we'll do our very best to make sure that we talk more about the nursing facility program itself in the months to come. So I think the next slide is for Amy, but so I will pass this baton over to Commissioner Amy Penrod.
Janice, if you wouldn't mind holding on just for 1 second, we do have a question on nursing homes from Representative Carpenter. If you wouldn't mind holding on and answering that for him.
Thank you, Mr. Chair. I'd like to get home tonight sometime myself, so I won't be very long, but this is an issue that is very concerning to me, the nursing home, quite frankly, the future of them. So you're talking about cost will increase, so we're going to do rebasing this year?
Well, Representative, what we will do is review the cost. So all the cost report data will come in to KDADS. We will look to our contractor, Myers and Stauffer, to help us massage all that data. And from that particular data, then we'll meet with the secretary, meet with stakeholders, and see where the costs, how the costs look in 2020. Representative, I will share with you, typically we would be able to predict pretty well what costs are going to look like in nursing facilities. We predicted for years, and you can compare, the rate of inflation to the costs, and it's fairly predictable. This year, we're just not confident that the costs that will be reported as allowed costs are going to be predictable. We just don't know. So at the moment, we will be prepared to share with Secretary Howard what those costs look like once our contractors had an opportunity to massage the numbers, the data.
Okay, so could we expand on a little bit of the rebasing? It's in statute that we'll rebase every 3 years, and the increase is a percentage?
Typically, yes, there is a statute that requires rebasing every year based on 3 years worth of cost report data. So we haven't always, there have been provisos in the budget bills for several years that based on your appropriation, full rebasing may not be an option. So that will depend on, obviously your appropriation, whether or not rebasing, there would be a full rebasing this year. And I think, Representative Carpenter, what I'm trying to communicate is 2020 costs we just aren't confident that we know what those are going to look like until we actually see them. So whether 2020 is a good year to consider in rebasing methodology, we don't know yet. We'd like to see the cost first and then follow up.
And then just one final question. What happened to last year's rebasing numbers, the increase to the nursing homes?
I believe you all supported a 1% increase that was subjected then to the allotment. I hope I've got my facts right on that. I should have that straight, and I think I do.
You do. Thank you.
Okay. Sure.
Janice,
Mr.
we
Chair?
have, yes, Representative Ruiz.
Thank you, Mr. Chair. I have a question, and if this is going to come up later on in the presentation, just let me know. I'm wondering about the surveys to the nursing homes and where we are with that.
You know, if you don't mind, that will come up later in the presentation.
Okay,
Representative
great.
Scott Bruner, who's our deputy secretary over the survey process, will have several slides that he'll go over soon.
Thank you so much.
Sure.
And Janice, we have one quick question from Senator Gossage.
Okay.
Thank you, Mr. Chair. Just a very quick question to make sure I understood what I thought I heard you say. Did you say that 50% of the nursing home residents receive Medicaid?
That is correct. That is correct. And actually, Representative Gossage, it's been interesting. That's fairly consistent, which we're not sure why, to be honest with you. We don't have an answer for that, but it's been consistent in Kansas that on any given day for years, about 50% of the residents, and there are about 20,000 on any given day in Kansas, do receive Medicaid. Yes.
20,000 total or 20,000 that receive Medicaid?
20,000 total, and about half those or 10,000 are on Medicaid. Yep.
Chair.
And Janice, we have a question from Representative Landwehr.
Thank you, Mr. Chairman. Going back to Representative Carpenter's question on the rebasing, Janice, did we get that corrected where the rebasing year is set now in statute and overrides the 7-year that was mentioned in rules and regs?
Yes, the statute is, yes, the statute refers to the previous 3 years, rules and regs. I believe Representative still talks about 7, but that's just because those rules and regs need to be updated, to be honest with you, so.
Okay, because that, I believe that may have been actually codified in statute maybe in 17, 18?
Yes, I agree with you, Representative. And if I may, you've heard the Secretary saying, you've heard me say, Representative, we do need to strengthen our nursing facility program as far as resources within the department. That is one area that we definitely have lost some resources, unable to do job duties such as updating regs, to be honest with you. So yes, we're fully aware of that. And that is an area where we need to recruit some more staff.
Okay, and then one last question, Mr. Chairman. Do you feel that we are doing a good job of actually monitoring the financial stability of our nursing homes out there? Because I believe what we heard last winter was that you guys might be in at least one of our facilities, that there's a concern about their financial stability. And then because we've also got the concern of the fact that the nursing homes were not given liability relief with the ERO. Are we in any more facilities right now, or are we looking that we may have some on the verge?
Is that your question? Are you directing that to me, or I wasn't sure, Representative Landwehr, to me or to the chair?
Well, it's either to you or to maybe Scott Bruner has that information. Because one of you provided that answer for us during the winter meeting, that we had at least one facility that you were actually in monitoring because of financial stability, because we don't want to end up with receivership issues. Do we have any new ones, or do we have or do we have any that we are close to maybe having to go in and monitor?
No, and I'll defer to Scott also, but no, at this point in time, we do not have any facilities. I believe that CMS has asked us to go in with temporary management, but Scott, you might contradict me on that.
Yes, Mr. Chairman, it's Scott Bruner with KDAD. We do have one facility that's under a temporary manager. It's not for financial reasons necessarily. It was based on their performance and infection control. I mean, and as you well know, Representative Lynn, where those issues all kind of run together. But the reason that we imposed the temporary manager as a remedy was because of the survey deficiencies that we found, and CMS authorized, actually CMS directed to take that action to put them under a temporary manager. That's not a receivership. There's a path out of temporary management, but we do have one facility that's under a temporary manager.
I don't want to see us in receivership, so that's why I was concerned whether or not we were looking at any that could cross that bridge that we don't want to cross anymore. So thank you very much.
You're welcome.
Yeah.
Okay, I don't see any further questions, so we can go ahead and continue.
Thank you.
Good afternoon, Chair and members of the committee. My name is Amy Penrod, and I'm the Commissioner for the Aging and Disability Community Services and Programs Group within KDADS. I will start my presentation by providing you the HCBS waiver enrollment numbers as of the end of December of 2020. As you can see, we are about at 9,000, a little over, enrollees in our IDD or Intellectual and Developmental Disability Waiver. Along with that, though, we do have a waiting list of 4,464 individuals on that waiver wait list. For physical disability, we have a little over 6,000 individuals that are currently enrolled in the waiver, and the corresponding wait list for that program is 2,027. And I think the next slide, please. I wanted to give the committee a little bit of an update on some of the priority programs that the Home and Community-Based Service team is working on and will be focusing on during calendar year 2021. The first is final settings rule compliance, and I'll touch on some of these in a little bit more detail in the next few slides. But final settings rule compliance, reinstating our Money Follows the Person program. You heard a little bit about that and have heard about that from our stakeholders who are very interested in seeing that program reinstated. We are currently working on waiver amendments that are also based on our stakeholder feedback. We are continuing to have dialogue with stakeholders and interested parties and providers about supported employment and how we can strengthen that program here in Kansas. We have had work groups regarding targeted case management and updating our targeted case management model. And I'll talk about that a little bit more in more detail here in a moment. We will also be sharing with you some information on our brain injury waiver and associated brain injury waiver policies. And then finally, our autism waiver renews in calendar year 2022. And based on the timing of that renewal, we will need to begin working on any updates or changes that we may want to make to that waiver this calendar year. Next slide, please. Okay, so I had mentioned that we were working with stakeholders in a work group to discuss the model that Kansas currently uses for targeted case management. We did convene a work group of around 40 individuals from various either provider types, various regions, and different interests across the state to a set of, we had 5 days of meetings during which we worked on a collective vision for targeted case management as we move into the future, as well as the targeted case management core values. We really felt like it would behoove us to establish a common vision and values, and that all stakeholders and KDADS will be able to use this information to design a model that meets our goals and the needs of our participants. We have established 3 primary goals of the targeted case management services as we look to develop a new model or update our current model. That would be to maximize participants' independence and community inclusion, to receive services that are consistent, person-centered, and culturally competent and equitable, and also to have a voice and method for advocacy for participants to advocate for themselves and also to have someone that can advocate for them when needed. Next slide, please. And so all of this is kind of culminating into a process. You know, we have some next steps lined out we want to conduct a comprehensive review of our targeted case management system using the stakeholder feedback and concerns and the issues identified during these work group meetings. Create a project model based on the review of those results, and then continue to work with stakeholders on any proposed changes to the model. As you can see from that diagram, we're looking for a model that's evidence-based, that's conflict-free, that has a component of state oversight, that we're focusing on learning and training management, that we're using data and we're technologically driven. We're supporting person-centered planning for our participants, and then also reviewing the rates and the way in which we allow providers to bill. So we'll continue to keep you updated on progress with that work group and those stakeholders. Next slide, please. Okay, next I want to talk to you about the brain injury waiver, and you heard a lot about that this morning. We are approaching a critical juncture in the program. The brain injury waiver has operated as a short-term rehabilitation waiver. In 2018, the legislature directed KDADS to expand the traumatic brain injury waiver eligibility to include acquired brain injuries as well as youth population. And that expanded eligibility has resulted in exponential growth in the number of individuals that are presenting for waiver services. So we are at a juncture where KDADS needs to adapt our policies and procedures to ensure that we can provide individuals and the ability to gain their maximum benefit from rehabilitation and then transfer off the waiver to allow others to receive assistance. And then on the right-hand side there, I did put a little timeline. I won't read through it, but that kind of walks you through the process from the legislative direction to expand TBI eligibility to where we're at currently. Next slide, please. Okay, so as I said, we're at a critical juncture at only 7 months into our state fiscal year, 2021. The brain injury waiver program has served more individuals than the approved waiver authorizes and indeed funds. So as you can see, the approved waiver and the approved number that is funded in our budget is at 723, and as of January 27th, we had served 739 individuals. So if growth continues at its current rate as we're projecting, we will see the annual unduplicated number of individuals served will far exceed our budgeted capacity of the waiver program in its current state. Next slide, please. So as it has been mentioned by conferees earlier today, no additional funding was appropriated at the time of the eligibility expansion to address the projected growth in this program. Without implementing a wait list for the BI waiver services and also implementing waiver policy reforms, we do project that the program will exceed its budget in both the current and budget year 2022. And we've provided these numbers as far as what we believe the shortfall might look like without a waiting list implemented or without any policy changes that would impact eligibility for the program. Next slide, please. And then as we have spent the last bit of time doing our KDAD staff, as well as bringing in some stakeholders, we have reviewed the waiver's key program areas: eligibility, service delivery, and transition. And we are attempting to make sure that we can address any policy changes that are needed to ensure that there's appropriate access for individuals to the waiver and waiver services, both in scope and quantity, to ensure individuals can make progress towards their individualized goals, and then to transition folks from the brain injury waiver as their individualized goals are attained and greater independence is achieved. We are very committed to working with our stakeholders in the review and implementation of any policy reforms, including consideration of any other ideas that stakeholders may bring to the table. I do believe we had a very productive stakeholder meeting earlier this week, in which it was very clear that our stakeholders were interested in participating with us and being active participants in helping us ensure that we can maintain this waiver and keep folks receiving the rehabilitation that they need in a timely manner. Next slide, please. Now I'm going to move on to the home and community-based service final rule. This is the, we've talked about this for several Bethel committees, but for those of you that are new, the final rule has to do with the environment and the setting in which individuals who are receiving home and community-based service waiver services, the settings in which they are receiving those services. So the goal of the federal final settings rule is to ensure that individuals are receiving those services in the most integrated setting possible, that the options that are afforded to all of us, to you and I, that individuals with disabilities have the same control or options as far as their integration within the community. So this is a very large project. The federal government has provided a deadline for states of March of 2023 to ensure that all sites that provide, all locations that provide home and community-based services will meet their guidance. And we have been busy the last couple of years now reviewing each and every site, provider site here in Kansas. Those initial desk reviews and assessments, self-assessments by providers have been completed. We completed over 2,800 of those. As far as our timeline right now, we are in remediation. And that means that for any providers that have areas of non-compliance, we are working with them and they are working towards becoming compliant. And for a lot of them, that just may mean updating policies and procedures, making sure that you know, they've got records that of these policies and procedures and things like that. And you know, like I said, we are committed to making sure that as many of our providers, all of the providers that want to come along and be compliant, that we can help them get to that point by March of 2023. As of February 4th, a total of 956 settings have started remediation. So about a third of our sites have begun the process, and we're working with those. As of February 4th, 146 settings had been deemed compliant. That number does grow day by day, week by week. Let's see, I asked a day or so ago, and I believe we were up to, I want to say 175 in that ballpark. So it does grow in kind of leaps and bounds as we move along. So let's see, and my coworker's being noisy, I apologize. I think we can probably move on to the next slide. Thank you. Administrative case management is a program that rolled out in May of 2020. It is new. You heard from Leslie Anderson this morning that the AAAs are offering this service. And you can see for the last 8 months, the program has grown steadily and assisting almost 3,000 individuals with their Medicaid applications and for the brain injury, physical disability, and frail elderly waivers. So we're very excited about that program. Next slide, please. And then finally, I wanted to provide you an update on our enrollment of the program of all-inclusive care for the elderly. You can see that the program in total across the state currently has 725 enrollees as of January 20th. And that I've provided the breakout there between the 3 different providers. And those providers, some of them have multiple sites. So the program is seeing a nice enrollment. And then our final slide, my final slide, is just a snapshot of the counties in which each of the PACE providers actually provide their services. So PACE right now is not a statewide offering. It is only available from these 3 providers and in these counties. So I'd be happy to stand for any questions at the appropriate time, now or later.
Thank you. It looks like we do have one question, at least from Representative Concanon.
Thank you, Amy. Thank you, Mr. Chairman. Is there any, do you have any intention of expanding PACE?
I think that the interest in expanding PACE is there, just from recent conversations with our PACE providers. I do believe there is interest in expanding into certain areas of the state. And so we are looking at what that process might need to look like. In the past, we've used an RFP process to expand and grow PACE. And so I at this point, I would assume it's a similar process as we move forward.
Okay, thank you.
Representative Landwehr. Yeah, I've got a question from Representative Landwehr, and then Senator Petty will go to you next, if that'll be okay. Thank you.
Thank you, Mr. Chairman. It's always good to see you again. I appreciate the information. Going back to the brain injury waiver, you made the comment about what we have authorized. Does that mean that the legislature put a financial cap on the brain injury waiver?
The brain injury waiver does have an appropriation that is specific to that program. Yes. So in our actual home and community-based service waiver document that is approved and reviewed by CMS, we do have to estimate the number of individuals unduplicated that we would serve within a year's time. And the number that we put into our waiver is based on our appropriation.
Okay, and then, I'm just kind of intrigued with the number that you're showing for FY 22, that if we don't create a waiting, okay, first of all, let me ask you, do we currently have a waiting list?
No, ma'am, we do not.
Okay. And if we're looking at your chart on page 15, 22 is showing that without a waiting list, that we're looking for the program to basically double. Is that correct?
Yes. Yes, the trajectory that the current waiver is on, if no changes are made, no wait list is implemented, and like I said, we do have some policy changes that we're working through, and we will be working through with stakeholders that may have some impact on the finances or fiscal note for the brain injury waiver. But all else equal, with no changes, we are projecting that we would eventually get to a doubling of the waiver.
Okay, it's my understanding, Amy, that the largest age growth in this is with children. Is that correct?
Actually, right now we only have about 17 children on the waiver. I would say the largest area of growth that we have seen has been stroke victims that are, say, 55 plus. That has been our experience, and that's what our data is showing right now.
Okay, so could we get a breakdown by age, if that would be possible? Just kind of look at the trend of this program. And then what my concern is, Amy, if we put people on a waiting list on the brain injury program, and let's say that waiting list is 2 years out, then we're dealing with permanent damage versus reversible damage. Is that be correct?
That makes sense to me, and I understand the concern there, and I believe we would like to do what we can to avoid a waiting list for those very reasons.
I guess, and Mr. Chairman, I want us to monitor this point, and the reason for that is, like I said, if we put them on a waiting list, then the chance for recovery becomes a lot smaller, whether it's kids or it's adults. It is a lot harder on the adults. Then when it becomes permanent damage, we can actually probably see an increase in our other Medicaid costs for long-term care of these individuals. Would that be accurate, Amy?
I think that would be a fair assessment or a fair assumption that would be possible.
All right. Thank you very much, and thank you, Mr. Chairman.
Senator Petty.
Thank you. Can you hear me?
Yes.
Yes.
Okay. My question goes right along with Representative Lamware concerning the brain injury waiver, and I'm looking at that slide and the projected fiscal note that you shared. I am concerned at how we are actually going to, I know you said that you're working on it, but how this is going to be addressed and absorbed without doubling the cost of the program in order not to have a waiting list. And it seems that a lot of it is connected to the legislation that was passed to change service. So could you expand on that a little bit?
Sure. Yeah, since we expanded the population, since we received approval and developed the functional assessment tools that were needed to implement the expansion of the waiver eligibility, we have been carefully watching the trends. And as you can see from one of those charts, in fiscal year 18, we had 515 unduplicated numbers of individuals served. It really was when we hit, between fiscal year 19 and 20 that we have seen a large growth and has continued to grow in an expanded population. KDADS did request an enhancement funding in its budget this last fall in anticipation of needing to support additional individuals on the waiver. That was not included in the governor's budget to this point, and I know that there will have to be some tough choices about how we move forward with the waiver. Either we need additional funding or we would have to implement a waiting list or some very, very severe policy changes. We're hoping that we can make some reasonable policy changes that will help us best manage the waiver as well as address some of that growth.
Thank you. And just as a follow-up, I know that Representative Lamware asked for some information and about how if a person isn't service through the brain injury waiver that they would have expanded costs otherwise through Medicaid or Medicare. And I know that what we're looking at, what you pulled up again, on slide 14, shows this increase. I can't remember now if Representative Weimer had asked for a breakdown, an age breakdown in this increase. Did she? Okay. So yes. I think that, and so with the age increase, could you also, would you be able to share, would you be able to forecast what is the potential period of time now that someone is going to be staying on this waiver as opposed to prior change in the legislation?
We do have data on the length of stay on the waiver that we could share. As far as predicting with the expanded population, what that looks like, different than the previous waiver definition where it was only traumatic brain injuries. I will look and see if there's a way to do that comparison. I know that we can give you a breakdown on length of stay on the waiver, how long average folks stay on the waiver, and what our current statistics are as far as the individuals that are on the waiver currently.
Thank you. Thank you, Mr. Chairman.
Representative Ballard.
Thank you, Mr. Chairman. It seems like with all the emails, this must be the topic of the week, and maybe last week too, because this week we had a pretty lengthy discussion on the brain waiver ourselves. And I think one of the concerns we had that with it being acquired, that maybe we would have more children on it, but Representative Landwehr asked that question and you indicated there were only 17 children on it. So the acquired must either be from strokes or accidents or a combination of things. And you said the larger population was 55 and over. Have the organization talked about what else? I'm trying to think how to word this. If the 55 plus is really the population now, how will we handle when we will get a larger number of children? I know the waiting list is what's out there, but have you talked about how we could handle that better in categories?
Yeah, and to be clear, and to clarify what I may have said earlier, I'm talking about the 55 and older stroke victims is probably our largest category of growth. It's not necessarily the, if you're looking at a snapshot of the whole entire waiver, it would not necessarily be 55 plus. We can get a snapshot of ages. We'll get you a breakdown of all of that. But the growth, I would say, has been more along the lines of stroke victims in 55 plus. As far as being able to accommodate children, I think that you know, we have as the state have the tools to assess folks' children's functional eligibility for the waiver. I know that it is a new kind of arena for some of our service providers. I do think that that there are several that stand ready, willing, and able to accommodate services for children when they present.
Thank you very much. Thank you, Mr. Chairman.
I don't see any further questions. And just a quick comment from me. I noticed there are 56 slides to this presentation, and we are on slide 20, and we are 20 minutes past our schedule. So just a comment, suggestion, encouragement for the next presenters. If you have a speedy way of delivering your presentation, that would be greatly appreciated. Thank you.
Hello, Chairman and members of the committee. My name is Andy Brown. I'm the Commissioner for Behavioral Health Services, and I promise to be quick. So this is my regular slide on updates around the psychiatric residential treatment facilities, or PTRF wait lists. Our current wait list as of February 8th was 80 down from 108 individuals in December. Of those 80 individuals, 18 were in foster care, which is up slightly from 14 in December. The current number of PRTF licensed beds is 412 in the system of care, and that's up from 386 in December. We anticipate that these increases will further reduce the waiting list in the coming weeks. And we are continuing to review our PRTF regulations and intend to have public comment on that soon. And then our meeting with the MCOs and DCF continues, and we continue to work with care coordination to facilitate services. So that's slide 1. Slide 2 is just an update on the Hayes Children's Hospital RFP. KDADS has issued an RFP to receive bids on providing the 8 children's psychiatric hospital beds in Hayes. The bid was posted, or RFP was posted last month. We have received questions from the bidders. We've responded to those questions. Proposals were due from bidders yesterday. And I'm happy to say that we have received a bid, and we will now review that bid and begin the process to award a contract. We anticipate being able to award the contract in March. And I'll stand for any questions.
Committee members, do we have any questions? I guess we don't have any. I appreciate your testimony. I do just have one quick one. On, you said bed space, is the moratorium being lifted on Osawatomie and Larned yet, or do we have a time frame for those?
I'll let Deputy Secretary Brenner respond to that, but we are currently working on a plan.
Thank you.
Mr. Chairman, I think that's the segue to me. Scott Bruner, Deputy Secretary of Hospitals and Facilities. For the new members of the committee, our agency has a programmatic side, which you've just heard about, that Janice is responsible for. I work with the regulatory side of our agency on nursing facilities and long-term care and state hospitals. So that's what I'll walk you through. I will probably go too fast, but I'm more interested in hearing your questions. So I'll go through kind of some of the standard things that we provide in updates to the committee. And I apologize. Before I do that, Representative Landwehr, I misspoke. We have 2 nursing facilities right now that are under temporary manager authority. That was the same as in when you met in December. It's not just one. So I was only off by 50%, but I did want to correct my statement. And both of those are for infection control reasons ordered by CMS as part of their enforcement action. And happy to answer more questions about that since I misspoke. For the committee's benefit, one of the items that we're asked to update on at every Bethel committee is where we are with nursing facilities and inappropriate use of psychotropic drugs of folks in nursing homes. And we provide this national data that's provided from the federal government to show where we rank. We're now 37th in the nation. And that's where we've been for the last couple of years with 16.1% of nursing home residents receiving antipsychotic medications. We're on a downward trend, but it's kind of leveled off. We've added to this in the last few Bethel presentations. That national data is helpful, but it's slow to update. That's actually updated from the last time that we presented. But I did talk to our 3 managed care organizations and asked them to provide and share with you data that they have on one of their pay for performance measures. That's the same kind of factor. And so we've got the data for all of calendar year 2020 on this slide, just to kind of show you for at least the Medicaid population what that rate of antipsychotic misuse looks like in the nursing home population. With that, the other topic that we're asked to update you about are priorities and issues in our adult care homes. And honestly, most of that over the last year and a half year has been COVID related. So we do, our agency, we have the policy side of nursing facilities, but then we also regulate and survey nursing facilities and other long-term care settings under a contract with the Centers for Medicare and Medicaid Services. That involves us, teams of our workers around the state, going into nursing facilities, doing on-site inspections and surveys on a variety of factors that are part of the licensure requirements for both Medicare and Medicaid services. And that includes nursing homes under the CMS contract and other kinds of adult care settings that are licensed by us in the state of Kansas. Since COVID, our primary focus for that survey activity on the nursing facility side has been doing infection control surveys. So we wanted to share on this slide where that federal direction comes from and really the prioritization that CMS has done to say state survey agencies need to focus on these federally required infection control surveys, the FIC surveys, and then that's really guided our action of what we've been taking on over the last year. That's changed a little bit over time. Early on, CMS said stop going into facilities until we got a better handle on COVID-19. Then they said only do infection control surveys, and now that's shifted a little bit to doing follow-up reviews and trying to get back on our regular schedule of annual surveys. And so you can see the factors here that we'd go into on a nursing facility survey. To give you a little perspective on where we are in Kansas, we completed 826 infection control surveys, the federally required infection control surveys over the last year. And the column on the far side of the table, they are averages, but the 57,000 is the national number of surveys that were completed. We've done 100% of those that were required. We needed to be in every facility, and we've done that. 11% of them resulted in a citation where we actually wrote a deficiency on a facility based on infection control. And you can see immediate jeopardy means a citation or a survey finding that means a resident in immediate jeopardy of harm. And you can see the percentage of those that we found from the surveys that we did. On adult care homes, you also in the last legislative session passed a bill, House Bill 2016, that required us to do those infection control surveys in all the homes that we license, both the CMS certified facilities and state licensed facilities. We've completed all of those surveys and did by September. And then our current activity is to kind of continue doing those where they need to be re-reviewed, but also going on to doing some of the annual surveys that we have to perform where it's getting close to the 15-month interval between surveys. And as I tried to describe, probably not well because I'm trying to go through it a little quickly, but so we have federally licensed nursing facilities and then adult care homes that are facilities like assisted livings, Home Plus homes, and some other categories that are only licensed, that operate under a state licensure, but we do survey them as well. The priority is a little bit different, but we are doing infection control surveys. We are trying to get back on the cycle of annual licensure surveys, complaint investigations, things like that. But we're not quite on a normal schedule yet, but we're working our way back to that. I did want to give you a quick update on testing in nursing facilities. A couple of themes here. The federal government over the summer sent testing devices into facilities directly to facilities in kind of 3 waves. These were antigen-based tests that used a nasal swab, and 319 nursing facilities received one of those machines and the supplies to use it to help implement the requirement to test all staff in nursing facilities. After that happened, the federal government, those facilities went to just nursing homes, and there was a realization that assisted living facilities and other kinds of facilities also needed help with testing. And so the federal government bought a supply of these Abbott Binax Now cards, and there's a picture of it on the slide. And those were sent out to nursing facilities and assisted living facilities as well at no charge, again, to help implement some of the testing requirements that were happening over this summer and fall. And then that complemented well into the state's testing strategy that happened in September and October, where there were state regional laboratories that, and I think you had a discussion with the secretary about that earlier, where that testing fit in. But this was, again, to help facilities test staff and residents as needed. I did want to provide one slide on vaccine, or maybe it's a couple slides on vaccine. And I think Secretary Norman addressed some of this as well, so I don't want to repeat. But for vaccine in the long-term care settings, there are at least two paths that were pursued. The federal government entered a contract with Walgreens and CVS to directly provide vaccine into long-term settings, nursing homes, and assisted livings. And so they took the primary role for that. This slide tries to characterize the results of that. There's some updated data that, but where we think we are now is about 48,000 people have received their first dose, 19,000 are fully vaccinated in Kansas based on that long-term care partnership. And some of that now, the partnership's concluded its efforts, and the excess vaccine that wasn't administered is being distributed back to states and redirected from there. One of the things we have been working on in cooperation with KDHE and the governor's office is to try to identify facilities that weren't part of the national partnership and didn't have ready access to vaccine. We started to call them orphaned facilities without meaning to be pejorative about that at all, but that they were somehow missing in the scope of some of these programs. So we worked with our list of licensed facilities, did a survey, worked with the trade associations, and pretty much made an open call to say, if you're an adult care home in Kansas and you don't know how to get vaccine, let us know. And then we connected them with the vaccine program at KDHE. And we went from having maybe close to 200 facilities that we hadn't connected out of our 820 facilities or so that needed to be connected. We've connected all but a handful, maybe I think it's a dozen now that we haven't either identified that they had vaccine or knew where to get vaccine, or KDHE worked with them. We worked with the consultants that the governor's office has been working with to make all of that happen. I want to give you an update about that. Visitation, I think Representative Kincannon asked a question about this earlier. For the new members of the committee, when the pandemic hit, CMS issued direction that nursing facilities needed to close outside visitors. We mirrored that guidance for our state licensed facilities to make sure that that residents were safe, that we were trying to control the spread of the virus. In September, CMS changed some of those restrictions to try to encourage facilities to reopen to visitors as much as they could, with some standards in mind of what to look for. And that included what the rate of community spread was, what the policies were at the facility level, what kind of capabilities they could have, like a separate room or an outside area that would work. And in that guidance, they let states provide grants to facilities to try to make some of those things happen. So the policy progressed over the course of the pandemic, but where we are right now is still largely closed, depending on what the level of community spread is. When we, really the difference is, and what people want is to be able to go into facilities and visit their loved ones, which we completely understand and know the impact that these prolonged lack of visitations had. So in our guidance and in the CMS guidance, it talks about how facilities can come up with plans to reopen to indoor visitation as long as there hasn't been a new onset of COVID cases in the facility in the last 2 weeks, and there's outbreak testing. There isn't any outbreak testing that's going on. They have the policies to support it, the staff to support it, all of those kinds of mechanisms. And in the guidance that we issued in the fall, we asked adult care homes to develop plans and work with residents and their family members to figure out what kind of visitation was possible and how to facilitate that. That's where our guidance has been, and that's what this slide tries to describe, of just kind of there is a variety of things happening around the state, but it is driven off the county rates of positivity of the virus, what the facility policies are, facilities working with local health departments to understand where the virus is and best practices, and moving forward from there. At this point, we haven't updated the guidance related to anything with vaccines. CMS hasn't updated their guidance related to vaccine distribution. We do monitor that on a regular basis and anticipate that'll happen at some point, but it hasn't happened yet. So we're trying to work with facilities that raise questions to address those questions and issues within the policy guidance that we've got in place. Here on this, I think last slide related to long-term care is just how much money we've distributed to facilities for visitation or assisted devices, iPads and things like that to help with remote visitation. But all of that's documented on the super tracker spreadsheet that Janice mentioned earlier. That was my long-term care part of the presentation. I've got a couple of items on the state hospitals that I can continue with, Mr. Chairman, or stop here for questions, whichever your preference would be.
We're on a very good pace, so I would hate to interrupt that.
It's a little bit from practice, but and desperation probably, but I haven't been sitting through this all day, and I'm not really listening to myself, so I apologize for that. So I'll just get through this and then open to questions on state hospitals. There's two issues that you ask us to update you on related to the state hospitals. We do have 4 state hospitals that I work with, 2 for people with intellectual and developmental disabilities at KNI here in Topeka, and Parsons State Hospital in Parsons, and then Larned and Osawatomie State Hospitals for people that suffer from mental illness. The 2 issues that we're asked to update you on a regular basis are the status of an executive directive that raised pay rates for direct care staff, nursing staff, and security at Larned State Hospital. This was done by Governor Kelly to address a disparity between the kind of starting wages of people who do similar roles at the correctional facility in Larned that happen at the state hospital. So I think the question was, if you were starting as a correctional officer, you could get paid more than a starting person who provides direct care or security on our state hospital grounds. So there was an effort to raise the pay rates to make them more equalized, with the hope that would impact the vacancy rate and our ability to fill positions. So there's some data on the slide about the rates over time. I didn't have an update for the end of the year on the different classifications, but I did have the overall vacancy rate. It did jump up a little bit in January. We've had some good recruiting classes. We've got some people starting. So I think that's more of an aberration than anything else, but it is a little bit higher was a little bit higher in January. We're working to recruit and hire staff as best we can. A couple of bullet points on this slide related to recruiting and retention efforts at Larned. It's really pretty amazing the amount of they've been working with Cox Communications and KSN to promote through commercials of describing the workplace and what it's like. But I've seen some good impact from that and advertising on Facebook and other online sources as well. That's changed a little bit because of the pandemic. It's made lots of things hard and difficult to implement. We have had to change capacity a little bit to have isolation and quarantine spaces. But we are still working to recruit and hire and fill positions. Related to hiring, another impact at Larned, or a factor at Larned, is holdovers. So we require nurses and others to be mandated to stay on for another shift. So when the staffing was at it's probably always at a crisis level, but a more severe crisis level, there would be nurses that be working multiple shifts in a week and then being asked to hold over. And the pay increase certainly helped with that, with recruiting and positions. So we've been providing this data for a while now on the number of mandates per day this is by day. And it's a very busy chart, but what hopefully you can take away from it is there's a downward trend. The slope is certainly moving in the right direction. And as there are fewer mandates, that means our staffing is higher. Staff aren't asked to do those extra shifts on a regular basis. And again, we think that's largely helped by the executive directive and addressing some of the pay issues. And then finally, the moratorium at Osawatomie is the other topic we're asked to update about. So last year, we proposed to the legislature you all approved some additions to the KDAD's budget to address inpatient capacity for mental health treatment around the state. There's a couple of components to that. One of them is the use of regional beds. So using community hospitals and psychiatric hospitals around the state to divert people who would otherwise be placed at Osawatomie or Larned. We asked for $5 million. That was included in the approved budget. Half of that was allotted out, so that number should be $2.5 million for fiscal year 2021. We've been using those funds, that $2.5 million that was added and $3.9 million that was already in our approved budget, to contract with providers to do diversion. And then we've adopted a Medicaid plan amendment and Medicaid state policy for something called state institutional alternative beds, which are community hospitals that serve essentially as a replacement for the state hospital. We've started entering contracts with providers for those beds. And as we expand that, that'll help with the capacity down the road. We're working towards bed expansion at OSH, which I'll talk about in just a second. And then getting other community hospitals enrolled as SIA providers. We've got some other information on community efforts to expand capacity that we're working on for a presentation to the House of Appropriations next week, so we can talk more about other initiatives, but SIAs is the big part. The other is building at Osawatomie. The approved budget for this year that you all approved last year included $2 million to let us increase the number of beds by 14 in our existing footprint of buildings. It was the staffing really and a little bit of remodeling to make that happen. We're moving forward with that. There have been a few delays related to COVID at Osawatomie. There's two, at Osawatomie State Hospital, there's really two hospitals on the same campus, and they needed to have separate isolation and quarantine spaces. So we've been using some of the space that would have been remodeled. We've been filling it with patients that had COVID or that we needed to isolate. That slowed down the process a little bit, but we are still moving ahead on some of those activities. The bigger part of the budget addition last year was $5.3 million from the State Institutions Building Fund to remodel part of another building, the Bethell building on campus, to become certified space that could be that could draw Medicaid and Medicare funding. And so for the first stage of that is what we call B2, the B2 unit remodeling. We're at 95% of the way through with the technical drawings. We're planning to release that for RFP for a contractor to do the renovation this April and then occupy it by September. That'll help increase capacity a little bit so we can do some of the other space movement that we need. East Bethell is really where the big additional bed space comes around. That one's a little bit further behind. It's a bigger project. We used more of that space for quarantine, but we're still on at best, we're somewhere between 6 and 9 months behind the schedule that we had talked about last year. All these things fit together into helping us lift the moratorium and making that decision. Largely, we need to get some of this bed space completed. We also need to get more providers recruited as state institutional alternatives, and that work continues through the year with the money that's been appropriated. Which this is what describes the movement and bed space changes. Apologize for that. So I'll leave that slide up and for your reading pleasure. And at that point, I would take questions, Mr. Chairman.
Scott, thank you. Committee members, do we have any questions for Scott? Scott, I do not see any. Except, what was the date? I didn't see it in the slide. If I did, I overlooked it. But what was and I think Representative Ballard told me December 12th or 21st was when the moratorium, when those will be lifted? The governor's moratorium?
Yes, it depends on some of the factors of how many beds we can get built. So last year in the plan that we proposed, the date that we set was like May of 2021. And I think we're about somewhere between 6 and 9 months off that schedule because of COVID and using in the building. So I think December is maybe the earliest we would think about it, but that would depend a lot on the community capacity we can build and how much of the bed space we get complete.
Okay, thank you. I don't see any further questions, so we can go ahead and proceed.
Okay.
Thank you.
I believe the last few slides are just some of the data that we're asked to provide an update. I don't think I'll walk through that unless Janice wants to make a comment about any of it, or the secretary would like to make a final comment, but I think that completes our presentation.
All right. Hey, thank you very much. Committee members, any final questions before we move on? Not seeing any. Scott, Janice, Amy, Secretary, thank you for your presentation. Committee, we will now move to our final part. Scott, did you have something?
I was just saying thank you for that, for your time. Appreciate it.
Okay, thank you. MCO presentations, Kevin Sparks, CEO, and Carrie Kimes, Director of Provider Relations and Strategy for UHC. Kevin and Carrie, welcome to the committee. Carrie, welcome back.
Thank you, Chairman Hildebrand and members of the committee. My name is Kevin Sparks, and I have the honor to serve as President and CEO of the United Health Care Community Plan of Kansas. The late, great Kenny Rogers said, "You need to walk away and know when to run." Chairman Hildebrand, I'm going to run, and we will get you on the turnpike as quickly as I can. So thank you all for your support. Marissa, if you could throw our slide deck up. I don't know if you have that in front of you. You've been outstanding help. Really appreciate that. Next slide. Director Ferdy provided a good refresh of the 115 waiver. I just want to emphasize that the three MCOs have collaborated with the state and have a great partnership with both KDHE and KDADS. And I just want to make sure that the committee knows that that has shined through during this pandemic. I didn't really think that I would be up here talking about for the fourth straight quarter how we're battling this pandemic, but that's what we're dealing with. Dr. Norman was correct in his testimony. COVID-19 has staying power. United Healthcare has learned, and Dr. Norman touched on many of the factors that increase the spread and impact of COVID-19. I would add underlying health conditions, low socioeconomic status, and lack of access to healthcare. Next slide, please. To battle this virus, UHC created the Stop COVID program. STOP stands for Safety, Testing, and Overall Partnerships. United Healthcare has been working the needs to serve the community of vulnerable communities, especially minority communities who have been disproportionately impacted by COVID-19. African Americans and Latinos are 5 times more likely to become sick from COVID-19 as compared to whites. Additionally, African Americans are 3.5 times more likely to die from COVID-19, and Latinos are twice as likely to die from the virus compared to the whites. Vulnerable minority communities also need the fundamental underlying factors that contribute to health inequity in our society to be addressed, including food insecurity. And what you see in front of you is a slide. We have some analytic tools that help with health disparity analysis. And 2 of the counties that you're looking at in Kansas are Wyandotte and Seward, and in particular, Liberal within Seward County. So UHC, we found that providing grants isn't enough to impact the health of these individuals. So we are providing the necessary services to multiple communities, including Liberal and Wyandotte. These services have included 10,000 health and safety kits and 6,000 free boxes of food. The health safety kits include masks, hand sanitizers, and personal paper products. Obviously, this work would not be possible without the partnership piece of the STOP initiative. If you could go to the last slide, I think that is the logo slide. Thank you. We partnered in Southwest Kansas with Genesis Clinic, the Kansas Food Bank, the United Way of Seward County, Southwest Medical Center, the Liberal Coalition of Families, and La Mexicana Radio, and of course, KDHE. Finally, I would like to remind the committee that Kansas has provided the public-private partnership work, and United has been working hard to make the health system work for all Kansas. During this pandemic, I am proud to say that we've invested over $4 million in the Kansas market to help with the battle against COVID. That is not required by the state. That is not required by our contract. That is us simply trying to make Kansas and the health system work better for the members that we serve. And with that, Chairman, I will stand for questions at the appropriate time.
Committee, we are going to hold questions for the MCOs until the end. David, next up, we have David Livingston, CEO of Aetna.
Good afternoon, Mr. Chair. David Livingston, CEO of Aetna Better Health of Kansas. And I, too, will be very brief. So can we put up our slides? We can go to the next slide. I always like to start with a member story. This isn't so much to put our accolades on ourselves, but to help people really understand, the members that we're serving, all of us, all the MCOs, in collaboration with our provider partners, and the agencies of the state. We're all committed to really improving the lives of those we serve. This member was someone who became newly eligible for Medicaid during COVID as a result of losing her job. She was a new mother and had an early delivery. She lived in a rural area and had to be taken to a NICU, a hospital with NICU services that was an hour and a half away. But because of KanCare, we were able to provide enhanced services. We were able to, after she delivered, we were able to, our care coordinator was able to work with her to get boarding and meals so that she could stay, didn't have to commute back and forth an hour and a half each way to see her child while the child was still in the hospital. We were also able to work with her to get some behavioral health supports that she may not have been able to get on her own. And also, working with the hospital to help her and other, to get her other needs taken care of so that, when it was time to go home, she felt confident and was able to take care of her child. Her child's still in the hospital, but she does have a solid plan of care in place for when her son is ready to come home. She's lined up resources in her own community to help her when she's able to return with her son, and really is appreciative of the KanCare program and helping her get things back on track. We can go to the next slide. So, we've heard a lot of talk today about support that we've all been providing, working together to provide. And again, this is not just Aetna doing this. This is in collaboration with all of the managed care partners, our provider partners, and the agencies and other community agencies throughout the state. I won't go through every one of these, but I think there's some pretty amazing statistics. We've talked about telemedicine. Prior to this pandemic, there was very little telemedicine within Aetna. In 2019, there were about 4,000 units of service. In 2020, over 125,000 units of service. So this is really, transforming the way that healthcare is delivered, bringing care to individuals across the state within the brain injury waiver, and also behavioral health, where they may not have gotten that care if we did not have this telemedicine extension. We've continued to use remote patient monitoring, and we have been able to educate members on flexibility in the waivers. In particular, one, I think we talked about this earlier in the technology assisted waiver, flexibility granted, if members and families didn't want outside individuals coming into their home out of fear, we were able to, through some working with KDAD, able to get family members to be able to serve in these roles rather than bringing in outside home health agencies. And we already talked about liberalization of the authorizations quite a bit earlier. And I think, one of the things that we did as an organization, and I think as all the MCOs, is really focused on eliminating friction for the providers. All of us delayed any overpayment recoupment activities and had focused efforts on making sure that we could get cash into the hands of the providers that were serving the members. You know, we talk about a new normal and whatever that means. And what I'm optimistic is that this new normal that we will see in Kansas is, you know, providers, payer, the MCOs working together with the agencies to really bring high quality care to our members and do that in a collaborative way to eliminate friction. The next slide has a little bit more statistics. And then the final story is just another member story that I'll let you guys read on your own time. But again, it's just a way that, you know, KanCare really does improve the lives that we are serving in Kansas. And, you know, we are proud to be part of this, proud to work with the state, proud to work with our providers, and proud to work with the other MCOs. So thank you very much. And I will wrap up and stand for questions when it's appropriate.
David, thank you for your testimony. Next up is Michael Stevens, President and CEO of Sunflower. Michael, welcome to the committee.
Good afternoon, Mr. Chairman. It's my privilege to be here, and I recognize that I am the final speaker of the agenda, and so I will also keep it brief. You have before you my presentation. I'd like to skip down a couple slides and also to share what we call a mission moment. We share these weekly in our employee town hall meetings as a way of making sure that we all stay focused on our mission. A little earlier today, Secretary Norman referred to the IDD population and some of the challenges of looking at them as a group, because in fact, within that group of members are many, many different demographics and different challenges. And this is a story of one of them who, in addition to being on the IDD waiver, has significant behavioral health issues and recently began experiencing issues with both hearing loss and vision loss. And so, as you can imagine, the caregiver team was broad and diverse. And one of the roles that a managed care organization is able to serve on behalf of the state is to bring together all of these caregivers along with family members to come up with a comprehensive plan of care to identify what might be occurring that's causing a member's decline, as in this case. Sometimes that ends up being medication interactions when multiple members of the team aren't normally in communication with each other. We're able to facilitate that through what we call our complex case management rounds process. And so I wanted to share that with you as a member story. If we drop on down below to slide number 5. Perfect, thank you very much. Just some examples of the continuing services that we're able to provide during COVID to make things easier for our members and for the providers that we work with in partnership. At the last Bethel meeting, there was a significant amount of discussion about the change in need of members as a result of kids being in either a home learning or a hybrid learning environment, and how their support services have needed to change. We continue to do that and have seen really good success, along with supporting members in HCBS services. I'm sure you can all imagine that during the last week, with the severe cold that we've experienced, that we had to spend additional time and make really a high level of focus those members that are homebound or self-direct their care, to make sure that their caregivers were able to make it to them and to make sure that they were safe in their home, particularly as we saw some of the rolling power outages. And so again, really just an advantage that the KanCare program gives us as an MCO to structure services around the needs of our members. And again, given our time, I will then conclude my remarks, but be happy to stand for any questions at the appropriate time. Thank you, Mr. Chair.
Michael, thank you very much for your testimony. And I know we have at least one question. Senator Stephan.
Thank you, Chairman. I think this is for Mr. Sparks. There at the start of your presentation, you threw out some data that I kind of wanted to to verify, because I do think it's important that we're quoting the same statistics. I'm looking at the COVID-19 cases in Kansas, the KDHE website right now, and it does talk about race death rates per 100,000, and it shows whites at 140 per 100,000, black or African Americans at 104, and Hispanics at 85 per 100,000. Is that the data you presented?
That's a great question. No, our data is nationwide. And so we use the analyzer that I showed you earlier in the slide to dive into the areas that we used in the database that we had gathered across the country on other statistics. And so no, that one didn't directly relate to Kansas. It was more on an aggregate across the country.
What were your numbers again, please?
Sure. Yeah, okay, so African Americans are 3.5 times more likely to die. Latinos are twice as likely to die as white people.
Do we have any further questions for any of the MCOs? Going once, twice. Gentlemen, thank you for your presentation for the MCOs. Committee members, that does conclude our meeting today. Do we have anything else that we need to discuss before adjourning? We're all good, Marisa? We got the okay from Marisa to adjourn, so committee, we are adjourned. Thank you. Everybody have safe travels home, and we will see you next time.